Hello, everyone. Welcome to our ATTR webinar for our Northeastern states. All of our previous webinars can be viewed on our website, amyloidosissupport.org, or on our new YouTube channel. We encourage you to subscribe when you join it. This webinar should be up there in about 2 weeks. We hope to be able to resume our live meetings in 2022. We realize the main thing missing from these webinars is the patient-to-patient contact, but that is available on our Facebook groups. We have a private group for our wild type and another one for our hereditary TTR. We'll put those up in the chat section so that you can see the links for them. Please don't put anything in the chat section. If you have questions, and we know you will during the course of this event, please type it into the Q&A. You can also type it in anonymously if you wish. Now, we ask that when you post the questions in the Q&A section, try to keep them as general as you can. We're not here to get second opinions today. But if you have anything that you feel is really important that you want answered, you can send a separate email to Muriel at amyloidosissupport.org, and I'll send it separately to our physicians. In the control room today, we have ASG's Executive Director, Paule Schmidt.
Hi, everybody. Thank you for joining.
And our Special Projects Director, Bob Gibson.
Hello, everybody. I hope you have a good presentation and session today.
Okay. Paula will be putting up various links in the chat section to be helpful for you. Our cardiologist members that are joining us today, and we have a very esteemed panel. We always do, but I think today it's really super, is Dr. Rick Ruberg from Boston University's Amyloidosis Clinic, Dr. Matt Marr from Columbia University. He'll be in and out today because he is on call. Dr. Farooq Sheikh from Washington MedStar, Dr. Vishal Parikh from Rochester Regional Health, Dr. Elizabeth Lee from Rochester Regional Health, and Dr. Sabu Thomas from the University of Rochester. The neurologists joining us are Drs. Michelle Keku from Boston University's Amyloidosis Clinic, Dr. Vincent Lau from Boston University's Amyloidosis Clinic, Dr. Thomas Brannagan from Columbia University, and Dr. Chafic Karam from the University of Pennsylvania. Last but certainly not least is the Assistant Director of the Boston University Amyloidosis Center, Dr. John Berk. We'll also hear some updates from our pharma friends today. With us will be Makenna Paule from Eidos, Gabriela Tamariz from Alnylam, Gustavo Buchele from Ionis, and Jeffrey Chihelski from Intelia. Our liaisons from Pfizer and Prothena could not make it today, but we did talk to them yesterday, and we will attempt to answer any questions that come up. Anything that we can't answer, we'll email to them, and hopefully they'll get an answer back to us. There will be a short survey for you to take when the webinar is over, or if you have to leave early, that will be available to you then as well. It's really important to us that you fill out these surveys because they really help us in figuring out what to do the next go around. So we do ask that you take the time to fill out the survey. Okay, we're going to start today with the cardiac presentation from Dr. Farooq Sheikh from Washington MedStar. Dr. Sheikh.
Thank you very much, Muriel, and thank you to the Amyloidosis Support Group for this kind invitation. I will now share my screen. Hopefully you can see this. Let's try to get it for full display. Excellent. So for the next 10 minutes, we'll do an overview of the signs, symptoms, and diagnostic approach for the evaluation of transthyretin cardiac amyloidosis. Just brief review for everyone joining us today. As you know, amyloidosis reflects a systemic process resulting in the extracellular deposition of insoluble fibrils composed of precursor proteins. We know that this is a protein folding disorder derived from a variety of serum proteins that can affect one or more organs, resulting in organ dysfunction due to tissue infiltration. This is shown here on endomyocardial tissue of obviously the heart, where cardiac myocytes are encased in amyloid deposited both in H&E stain as well as trichome stain here on the right. More than 90% of all cardiac amyloidosis relates to one of two precursor proteins. Beyond the scope of today's discussion is the sort of hallmark disease, AL amyloidosis, obviously A for amyloid, L for light chain, the precursor protein. But for the next 10 minutes or so, we'll be focused on transthyretin cardiac amyloidosis, known as ATTR amyloidosis, a disease where the protein of interest is predominantly made in the liver, shown here in this cartoon from a nice article by Brett Sperry, Mazen Hanna, and colleagues at Cleveland Clinic. And this protein circulates in the blood, and unfortunately, either through a genetic change, a substitution in an amino acid, or through the aging process, this protein dissociates, forms, aggregates, and in that misfolded form forms amyloid fibrils. We now know that over the last 10 years or so, there's been a heightened awareness of this disease. This heightened awareness, coupled with the advent of non-invasive tools for the diagnosis of the disease, has resulted in a remarkable increase in the incidence of amyloidosis, both wild-type disease as well as hereditary amyloidosis, from this very nice review article by Rick Ruberg, Matt Moore, and colleagues, which highlights this. Well, what about the presentations of ATTR disease and cardiac amyloidosis in general? The hallmark disease is heart failure, which is usually brought on or noted by breathlessness, either at rest or with exertion, or with edema, classically in the lower extremities, though it can occur in the abdomen and other areas. Another important form of the presentation can be chest discomfort. In this medical term is angina, in the absence of coronary artery disease. Other forms include syncope, fainting, or the feeling like you might faint, or lightheadedness, which can be related to conduction disease, the feeling of palpitations, which may be related to atrial or ventricular arrhythmias. And unfortunately, the first evidence of cardiac amyloidosis might be through a thromboembolic event, such as a stroke. There are echocardiographic and ECG features, which we'll discuss in a minute, that can also be the first marker of the disease, as well as a presentation of pericardial fluid, which could also be a first presentation. Clues from clinical history are worth noting. Hallmark form of the disease, which we'll talk about in a second, is heart failure with preserved ejection fraction presenting after the 6th or 7th decade of life. This, coupled with other features shown here in another very nice review article by Kier Shah at MCV in collaboration with Dr. Moore from Columbia, highlights other presentations. A family history of heart failure is a very important feature, why a review of systems and a past medical history is very important, as well as a family history. We mentioned angina in the setting of normal coronary angiography. Bilateral carpal tunnel disease, which is an extracardiac manifestation and many times may be the first manifestation. But another important point is for patients who might present with heart failure due to reduced ejection fraction, where the pumping function of the heart is less than normal, as measured by this percentage known as ejection fraction. Your symptoms might progress despite traditional clinical interventions with the use of drugs that have been shown to improve survival in systolic heart failure, but do not help patients with amyloidosis. What about cardiac comorbidities and ATTR cardiomyopathy? Well, the classic disease is heart failure, either with preserved or reduced ejection fraction. Again, ejection fraction refers to a measurement in a percentage of the pumping function of the heart. Aortic valve stenosis is now an increasingly recognized form of a comorbid condition. Atrial fibrillation, which is a feared complication of ATTR cardiomyopathy because of a high risk of stroke. We look for this preemptively in the treatment and the evaluation of patients with amyloidosis. Other forms of conduction disease, including complete heart block, can be seen, first-degree AV block, amongst others. Ventricular arrhythmias might be the first form of presentation or a comorbid condition, and then again, thromboembolism. Let's focus for just a minute or two on heart failure and aortic valve stenosis. Well, specifically heart failure with preserved ejection fraction is worth noting because it might be the first way in which this disease is presenting. Selma Mohammed and colleagues at the Mayo Clinic actually presented a very nice paper now 7 years ago in the Journal of the American College of Cardiology Heart Failure subjournal, which asked the question that in post-mortem analysis of patients with both heart failure with preserved ejection fraction or patients who are age-matched controls, what was the prevalence of deposition of wild-type transthyretin deposits in these patients. And if you see in the larger graph here with the x-axis being age and the y-axis being percentage who had amyloid deposition, you see an age-dependent phenomenon with patients with heart failure with preserved ejection fraction in black versus those control in gray. And you see an increasing percentage with age. In the smaller curves, you see separated control and heart failure with preserved ejection fraction, with blue signifying male patients and females in red. And this is a disease, particularly in wild type disease, that has a male predominance. Again, an age-dependent phenomenon. This signal, first identified by this group here at the Mayo Clinic, has been further accentuated by recent work by Johns Hopkins investigators and collaborators, where they demonstrated that as many as 14% of patients with heart failure with preserved ejection fraction may have concomitant cardiac amyloid deposition. Aortic valve stenosis is a fascinating aspect also of ATTR cardiomyopathy. And this paper by Adam Castaño, Matt Moore, and colleagues from Columbia University asked the following question. If we screen all patients undergoing evaluation for transcatheter aortic valve replacement procedure, what percentage of them may have concomitant cardiac amyloid deposition, specifically transthyretin deposition? And in a study of 151 patients, they found that 16% of patients, shown here in this graph, on the left, 16% of these patients actually had evidence of ATTR-CM manifested by imaging known as PYP imaging, which we'll talk about in a second. They also identified clinical demographic features shown at the bottom on the left, electrocardiographic features that were suspicious or consistent with cardiac amyloidosis, and then echocardiographic imaging features that were very classic for the disease, which allowed eventually them to identify patients with cardiac amyloidosis during this evaluation process. This evidence has been advanced by a number of other investigators, both in the United States as well as in Europe. And this multi-center study from Vienna and England highlights this. Very nice paper from more than 400 patients evaluated for transcatheter aortic valve replacement surgery. And what they found was that cardiac amyloidosis was very common in this elderly group, a group whose mean age was 83 years. 1 in 8 people being evaluated actually had cardiac amyloidosis. The presence of the disease could be predicted based on a clinical score, with clinical features shown here on the bottom right. With increasing score, the higher sensitivity and specificity. I should change that to higher specificity for the disease. And the transaortic valve replacement procedure was a reasonable treatment option, which both this group and others have shown have comparable survival to those who do not have cardiac amyloidosis. Imaging is at the center of the evaluation of patients with ATTR-CM. And the cartoon from Sharmila Dorbala and colleagues in Boston highlights this, which basically we have to remember that in cardiac amyloidosis, this is a disease where there is expansion of the extracellular matrix. If you think of the heart as a brick and mortar structure where the bricks are heart muscle cells and the mortar is the skeleton of the heart, which is known as the extracellular matrix, in amyloidosis, there is expansion of the extracellular matrix. And so we can use ECG, EKG or electrocardiogram, echocardiogram shown here on the top right with various tools. First, the imaging showing thickening of both ventricles, your right ventricle here, your left ventricle here, with enlargement of the atria. And then you can assess the diastolic or the relaxation properties of the heart, which will be abnormal. And then you can actually look at the excursion of the heart from the base to the apex in a technique known as global longitudinal strain, which also highlights abnormalities. This signal is then further advanced or accentuated and augmented by cardiac MRI, which is shown in that middle panel with various tools, including contrast utilization known as gadolinium, which shows diffuse uptake of gadolinium in this panel here within the LV, and then expansion of that extracellular matrix known as ECV or extracellular volume of greater than 40%. And finally, on the bottom is the bone avid compound tool known as cardiac scintigraphy, technetium pyrophosphate imaging, which is seen both in planar view as well as in SPECT imaging, showing enhancement of the left ventricle. These diagnostic tools can be used in various stages, and this very nice cartoon by Matt Moore and colleagues highlights at the appropriate test at the appropriate stage of disease. Our goal is obviously to find the disease earlier in the disease process so as to change the natural history of the disease. We've moved from treating the disease in a reactionary way to now screening patients. And Ron Watilis at Stanford University and colleagues highlight this in this very important review article where they mention important red flag signs and symptoms, both through imaging and then clinical history, and then make an argument why we should be screening patients for ATTR-CM who have one or more red flag signs or symptoms and an increased wall thickness, which they make the point of 1.4 centimeters or 14 millimeters in men over the age of 65 or women over the age of 60. And there's some debate as to what the parameter should be, but the point is we've now moved towards screening for the disease. Cardiac scintigraphy deserves a minute or two, and we could spend a lot of time on it. But for today's discussion, let's just say that this technology has revolutionized the field because it now allows us a non-invasive way to make the diagnosis. The key here is we must exclude a plasma cell dyscrasia because remember, AL amyloidosis can also be a form of cardiac amyloidosis, and it is uniformly fatal, unfortunately, if you do not get chemotherapy. It's an emergency, and we must make that diagnosis right away. So the first thing we do, as I'll show you in the next slide, is we must exclude a plasma cell dyscrasia. And if we do that, then we can proceed with this bone-avid compound imaging tool known as cardiac scintigraphy, which in the United States we use technetium pyrophosphate. Another tool is used in Europe. And we develop a both qualitative score and then a semi-quantitative score. And we make a diagnosis in individuals who have a grade 2 or grade 3 uptake, which is either equal to uptake within the ribs or greater than uptake in the ribs, and with a semi-quantitative score based on the heart to contralateral lung ratio of greater than 1.5. Lots of caveats about false positives, false negatives that are beyond today's discussion, but in interface with your cardiologist and your amyloid partners, you can certainly discuss this so as to make sure that we make the proper diagnosis. And this last slide brings everything together. We have a clinical suspicion of cardiac amyloidosis through history, clinical clues, initial imaging. We augment that signal through echocardiogram, cardiac MRI, which will give us further inclination. We then proceed with excluding a plasma cell dyscrasia, which we do with a serum and urine immunofixation test, as well as a serum-free light chain assay. If it is positive, we cannot go down the cardiac scintigraphy pathway. We must go down the gold standard pathway, which is biopsy of an affected organ. And so in our program at MedStar, we choose to biopsy the heart if we think that there is evidence of cardiac amyloidosis, though other centers may choose other forms of tissue biopsy. If there is no evidence of a plasma cell dyscrasia, we then can proceed down the PYP pathway, finding either bringing in the diagnosis of cardiac amyloidosis or excluding the diagnosis, with the caveat being that there can be false negatives. So if your pretest probability is high, always go to the gold standard, which is biopsy. And with that, I thank you very much.
And we thank you. That was really wonderful. I have a couple of quickie questions. First of all, can you send me that presentation? Because a lot of people are going to be asking for it.
It's already in your email.
Oh, bless your heart. Okay. We have our doctors trained, folks. Just want you to know that. Okay. You mentioned something about as high as 1 in 8 after a certain age will test positive for ATTR amyloidosis. Being a woman, and you said earlier that it seems mostly men get this, can I be safe in assuming that I likely won't be that 1 in 8?
It's a wonderful question, Muriel. Thank you for asking it. Remember, wild type disease has a predominant male phenotype. It disproportionately affects men, but I am blessed to take care of many women who have wild type amyloidosis. Not to mention, one of those patients actually was diagnosed at the time of TAVR screening. So the answer is women can present with wild type ATTR disease. It's not unheard of. It exists. In fact, I'm blessed to take care of women in their 80s and 90s who have it. And so what I would make the point here is that we have a clinical tool now, a scoring system that helps guide us for the diagnosis. And so many centers are now, particularly in the proper age group, screening all patients for the disease, or at least looking at echocardiographic and clinical history to increase or decrease the pretest probability. So I would recommend not to make the assumption that if you're a woman, you do not have ATTR cardiomyopathy just because you're being evaluated for TAVR. We should work with your cardiologist and non-cardiology partners to exclude the diagnosis.
That's a downer, but I thank you anyway. Okay.
Thank you.
Next, we will hear from Dr. John Berk at Boston University, current treatments for wild type ATTR. So Dr. Berk, are you there? You are muted. There you go.
Yeah, you've wanted to mute me for a long time, Muriel. Let me share my screen here. And eeny, meeny, miny, mo. Okay. All right. So can you guys see the screen?
Yes, we can.
Okay, fabulous. I have to say, Farooq's presentation was outstanding. I learned things, and I'm not sure I can keep up with him, but here we go anyway. So let's talk briefly about the treatment for cardiac amyloid. It's sort of going to be a theme throughout the process here. Oh, that's interesting. So the first foray into a therapy targeting cardiac amyloid, whether TTR or AL, is a nutraceutical, which is EGCG. And EGCG is a component of green tea. So in one study with examining TTR amyloid cardiomyopathy, there were 14 patients. This was the dosing of EGCG over a year. And the findings were that structurally there was no change detected by echo. That the cardiac MRI, there appeared to be a small decrease in left ventricular mass. In the AL population, there were 59 patients, similar dosing in conjunction with AL amyloid treatments, and that's important. We know that effective AL amyloid treatment not only knocks down the toxic protein, but also can induce some remodeling of the heart over time. And the findings, there were 11 patients that had more than a 2 millimeter decrease in that middle wall, that septum, and this was over a 6-month period. So if you look at those 11, you can see that in the first graph here, that the septum, that middle wall, decreased in all of these chosen participants, and left ventricular mass had a similar trend. But there was a more contemporary randomized clinical trial performed in Germany, and it was placebo-controlled. And unfortunately, the preliminary results seen here were not replicated, that there was no benefit seen in those with TTR amyloid cardiomyopathy receiving EGCG. So the big news dating back to 2018 is that Pfizer and tafamidis were shown to have a drug, tafamidis, that's impactful for TTR amyloid cardiomyopathy. What do you get for $225,000 a year other than a big bill? Well, you get improvement in disease course. In this graph here, looking at all-cause mortality, you can see that the two curves separate, and they separate at about 18 months. So you take the drug for 18 months, and you can see those that were receiving tafamidis had better survival than those who were on placebo. And if you look to see time to first cardiovascular hospitalization, the two curves separate at after about 9 months therapy. And you can see that there were fewer cardiovascular hospitalizations in the blue graph, that is the pooled tafamidis graph, versus placebo. Now, I want to extend the observation to a 6-minute walk test and the Kansas City cardiomyopathy questionnaire, a quality of life metric. So in the first graph, you can see that the blue curve has better preserved walking ability than the red curve. So the red curve is placebo, the blue is tafamidis. So in other words, if you're treated with tafamidis, your ability to walk distance is better preserved. And if you look at quality of life is better preserved than in those who are on placebo. But if we go back and we look at all-cause mortality, and we look at cardiovascular hospitalization, and we look at 6-minute walk tests, and we look at quality of life, although there are better outcomes in people receiving tafamidis, all of the curves are headed downhill. All right, with me? So if that's the case, we have a drug that is slowing the course of disease, but not stopping it. If you look at the echo data, comparing how the hearts looked at the beginning of the study versus how they looked at the end, and in this column, these are patients who were all receiving tafamidis. So they were comparing their initial findings to their final findings. In none of these categoric measures of an ultrasound of the heart were there any changes. And there are two ways of viewing that. One is, well, tafamidis prevented progression, and the other is there was no apparent drug-related remodeling of the heart. So if you've got a heart that's full of amyloid, tafamidis is not going to reverse the process. Patisiran in the Apollo study. Now, this is a study, the original study was for patients with neuropathy, but fully 60% of the people who were recruited to that study had concurrent cardiomyopathy. So they had full spectrum disease. And if you look at the data, and again, we're looking at 18 months here. In the last slide, we're looking at features of the heart at 30 months. Now we're looking at 18 months. And if you look at the thickness of the left ventricular wall, there is a signal here with the blue column being patisiran treated patients versus placebo, which is the gray. And you can see that approximately 30% of people actually had greater than 2 millimeter decrease in that wall thickness at 18 months, which is something that was not seen with tafamidis at 30 months. And then if you look at global longitudinal strain, as Farooq was just talking about, which is a fancy measure of how the heart squeezes, you can see that there is 20% of the patients receiving patisiran who actually had a decrease in the longitudinal strain, which is to say that actually improved systolic function, so improved squeeze of the heart. So these are small numbers. These are the study was not designed to really assess this, but it gives a suggestion that a TTR gene silencer has the potential to start a conversation where there may be the ability to remodel the heart, and as opposed to a mere slowing of the course of disease without any remodeling potential with a TTR protein stabilizer. Now, again, there's a lot of advertising about tafamidis and its ability to alter the course of TTR amyloid cardiomyopathy. What about diflunisal? Well, diflunisal works in the same mechanism. It's a different drug. It has anti-inflammatory capacities, which also may make the dosing a little more complex. This is a single center experience, although I would say at Boston University, although I would say that the Cleveland Clinic and Columbia University have similar experiences. This is looking at the population And I would say, before you look at the graph, that it's important to recognize that the control group here is actually somewhat sicker than the diflunisal group, which is kind of understandable. We select patients with TTR amyloid cardiomyopathy who we think can tolerate the drug. Then that would mean that their kidney function is fairly normal and that the degree of congestive heart failure is not severe. In contrast, the control group that was selected here are those people who had TTR amyloid cardiomyopathy, but did not get diflunisal and were not on another therapy. These people tended to be somewhat sicker, as you can see by some of the statistics here showing that BNP, creatinine, ejection fraction were all significantly worse in this group. But if you look at the survival graph here with the people who were the control group, you can see they have a rather dramatic downhill course in survival over years. In contrast, those who could tolerate diflunisal did remarkably well. And our perspective is that if you choose the population properly to treat with diflunisal, that you can get a similar outcome to what was achieved with tafamidis in the randomized clinical trial. And I think that's what I have to tell you right now. There are going to be other talking points that come up, and there are exciting new trials that are ongoing to tell us whether those initial findings with patisiran in the Apollo neuropathy study really extend and truly predict how TTR gene silencers will do in TTR amyloid cardiomyopathy. And with that, I will stop.
Well, thank you very much, Dr. Berk. I think we can all pick up from this some very interesting information, but let me just first say one thing. Doxycycline is something that people are often talk about taking, and I know BU had a study on doxycycline. You had hundreds of people in it with all types of amyloidosis. What were the results of that? Where do you stand when it comes to doxycycline? We know where you stand on so many other things. So where do you stand on doxycycline?
I like to fish. That's one thing I want everyone to know. In terms of doxycycline, the number of people that were in the trial was not large. They were treated for a year. There were significant numbers of people who discontinued drug either because of sun hypersensitivity or GI intolerance. That's point number one. Point number two is that doxycycline in animal models causes TTR amyloid to simply disappear. That is not true in human beings. So that was really our intent in doing that phase 2 study. So we didn't see it. We didn't have an ongoing placebo group, so we really can't compare. People didn't progress in their TTR amyloid cardiomyopathy, but they didn't improve either. So is that a good outcome? You'd only know that if you had an ongoing placebo group. So we can't be definitive. I think we default to doxycycline when patients are inappropriate or ineligible for other more established therapies, diflunisal, tafamidis, and then potentially trying to take advantage of the fact that TTR gene silencers are available for those with hereditary disease, identify neuropathy, which justifies use of the drug, and indirectly treat the cardiomyopathy that's present.
Thank you. Please hang around. There's going to be lots of questions.
Sure.
So thank you so much. We really appreciate it. And next, we're going to hear from Dr. Rick Ruberg from Boston University in regards to treating the symptoms. So Dr. Ruberg, take it away.
Thank you, Muriel. I'm gonna share my screen now. Okay, can everybody see my screen?
Yes, it's not on full presentation mode. There you go.
How's that?
That's
Great.
perfect.
Wonderful. Thank you. Look at my time here. Great. So thank you all. It's a pleasure to be here on a Saturday afternoon on the East Coast. Thank you, Muriel, for the invitation. And it's a pleasure to be part of this, this illustrious panel and to follow those two outstanding presentations. It's always difficult to follow Berk. I'll do my best. And you'll hear me reiterate a number of the things that Dr. Sheikh made in his initial presentation. I've just appended my title back to the basics. I'm talking about symptoms, but this presentation is going to be less about data and more about the big picture. And I do that because I want to make sure we're all on the same page in terms of understanding what amyloid does to the heart and how we treat the symptoms of it, rather than treating the amyloidosis directly or making the diagnosis. So I apologize if I'm insulting anybody's intelligence. I certainly don't mean to, and I'm happy to answer any questions in the Q&A. So let's go back to the basics. What is the problem here? And this particular illustration is of amyloid light chain, but it's the same thing true for transthyretin. The problem is that you've got misfolded protein fragments that basically lodge themselves in between normal heart muscle cells in cardiac amyloidosis. And that's illustrated in this figure here. It's nicely made green because of the green birefringence that you see under certain microscopy conditions. But the amyloid basically goes in between the heart muscle cells. It can hurt the heart muscle cells. And in so doing, the heart becomes thicker and it becomes stiffer. And then the whole wiring process of the heart becomes interrupted. And so that leads to situations, clinical situations of congestive heart failure and arrhythmia. And those are the things I'm going to talk about today in terms of how we treat them. The way I explain it to patients is imagine you've got a balloon and the balloon has a specific thickness to it, and you have to blow into that balloon to inflate it. With congestive heart failure, you can imagine that if the balloon is thicker and stiffer, you have to push a lot harder. A lot more pressure is required to open up that balloon. In this case, for the heart to prime itself and to fill, more pressure is required, and that leads to congestion. We'll talk about that in a moment. This is the one imaging slide I have. I'm an imaging cardiologist, so this is what I do for a living. And I just want to illustrate to you how different the heart looks with amyloid versus without. On the right, this is an ultrasound image of the heart showing the heart squeezing. And each of this donut here basically is the heart and the different walls of the heart muscle. And you can see how thick this is. Each one of these dots is 1 centimeter, and the heart here is about maybe 8 millimeters thickness. This is, on contrast, is a different patient with amyloidosis. Each one of these dots is a centimeter, but you can see here, this is almost 2 dots thick, 1.5 to 2 dots thick. The heart muscle is much, much thicker here. And this is what amyloidosis does to the heart. It makes it thicker. But you can see here that the squeezing function of the heart, even though you're obviously not all echocardiographers, still looks really good. And this is something that Dr. Sheikh alluded to. This is called heart failure with preserved ejection fraction. The heart is thicker, but the ejection fraction or the squeezing function of the heart is preserved and normal. Very characteristic of cardiac amyloidosis. What are the signs and symptoms of congestive heart failure? Shortness of breath, we've already talked about that. And the shortness of breath really could occur in many different scenarios. Typically when patients are at rest, just sitting, talking to you, watching TV, they don't get shortness of breath. But if they exert themselves, climb stairs, walk up inclines, try to exercise, they can develop shortness of breath. Lying flat, lying on their backs, that can also precipitate shortness of breath. We call that paroxysmal nocturnal dyspnea, when they wake up short of breath, that's a medical term, or orthopnea. They need to raise their bed of their head up, their head up with pillows or the head of their bed to make themselves breathe better. And this is particularly noted at night. Swelling of the legs or swelling of the abdomen, also mentioned by Dr. Sheikh, because that high pressure gets transmitted to the rest of the body. It gets transmitted to the lungs and causes congestion in the lungs, and it gets transmitted to the legs and causes congestion of the legs and of the abdomen. Low blood pressure, because the heart doesn't adequately circulate blood, and the blood pressure gets to be low because the cardiac output, the amount of blood squeezed by the heart with each cycle, is low, and the heart rate tends to go up in that setting too to maintain output. And this just generally causes people to feel tired and weak and have exercise intolerance. These are signs and symptoms of congestive heart failure. What about arrhythmia? I mentioned there's a wiring problem. Well, the most common heart arrhythmia associated with cardiac amyloidosis, ATTR amyloidosis, is atrial fibrillation or atrial flutter. And we'll talk about that in a moment. But 80% or more of patients with wild type ATTR amyloidosis will have atrial fibrillation or atrial flutter at their time of their diagnosis. And pretty much everybody with this type of amyloidosis will have some atrial fibrillation, atrial flutter over the course of their lifetime. It's that common. Bradycardia is a term for slow heart rate. Bradycardia could occur for a bunch of different reasons. One of the reasons is that the pacing part of the heart is abnormal. We call that sinus node dysfunction. Another part could be because the wiring of the heart is frayed, and I'll show you that in a moment. And then we call that AV block or heart block, and that could lead to slow heart rate. Another problem is fast heart rate. We call, and the most ominous fast heart rate is called ventricular tachycardia or ventricular fibrillation. That's less common in ATTR amyloidosis, but still something we think about under certain situations. What are the symptoms of arrhythmia? Palpitations or fast heartbeat, passing out unexpectedly, or dizziness, bouts of dizziness that are unexplained, or just a general irregular heart rate. You feel your heart skipping in your chest, or if you have a watch like I do, it gives you an alert that tells you that your heart is irregular. This is an illustration of the electrical system of the heart. So the heart's got 4 chambers and the top, 2 on the top and 2 on the bottom. And the heart rhythm impulse is actually originated from the top of the right side, and that's called the sinus node. And then it transmits through the atrium, through this wiring system into the ventricles, through things called bundle branches. And the wiring can be destroyed in cardiac amyloidosis, leading to blocks and problems where the conduction is abnormal. The heart still beats, but it does so not through its normal wiring method. Atrial fibrillation is a situation where the top chambers of the heart no longer beat rhythmically. This is an ECG illustration of a normal ECG. And the atrial contraction is illustrated by this thing called a P wave. You don't need to know that, but note here that this little bump doesn't exist before every one of these little squiggles. And this is atrial fibrillation because the P wave goes away. The heart starts beating arrhythmically. And because the top chamber of the heart no longer is setting the rate in a regular way. Atrial fibrillation has problems in that it predisposes patients to the risk of blood clots in the heart that can cause stroke or embolization or traveling to elsewhere in the body. And for that, we usually treat with anticoagulation. What is congestive heart failure? Just to dispel a few things, congestive heart failure is not a heart attack. Totally different. Heart attack in cardiology, when we say heart attack, we mean myocardial infarction, a blockage in the coronary artery, different process. It's also not a cardiac arrest. Cardiac arrest is when the heart stops. That's obviously a very, very serious problem. Congestive heart failure can lead to a cardiac arrest, but it in itself is not the same thing. Congestive heart failure is a problem with the heart muscle itself, where it inadequately circulates blood to meet the requirements of the body at a given time. So you could be at rest and your heart's doing fine, but you try to exercise and it doesn't meet the requirements, it doesn't augment its function. And that would be a form of congestive heart failure. Or it can meet the requirements, but it doesn't do it at the right pressure. And it needs higher pressure to do its job. And that pressure is transmitted back to the rest of the body, causing congestion, the symptoms that I mentioned to you. We think about congestive heart failure as compensated or decompensated. This is an important understanding because once someone has heart failure, they kind of go in and out of heart failure as the conditions change. The demands on their heart change, or the basal conditions change, the amount of fluid they have in their body, or the demands that are placed in their body, say by another infection, or changes in kidney function. It's a constant sort of balance between all these different parameters. And you can go from compensated to decompensated. And if you're decompensated, you may need to come to the hospital to become compensated again. And it becomes kind of a constant sort of, as I said, adjustment to different conditions. And this is why when patients have congestive heart failure, we treat them with regular medications that they have to take all the time, because if they don't, they run the risk of going into decompensation. How do we figure out whether someone's compensated or decompensated? Well, it depends on their symptoms, like I showed you, swelling, bloating, shortness of breath, weight gain. These are all things we look for, or by physical findings, like I said, swelling in the legs or symptoms. We do lab testing to determine whether someone is compensated or decompensated. We do that, so for example, we use the testing BNP or NT-proBNP. Just a word about those two tests. They're kind of the same molecule, but they're different. The scales are totally different. So you can't compare someone's BNP to someone else's NT-proBNP. Totally different scales. And we'll talk about that in the Q&A if you have questions. Look at kidney function. Worsening kidney function can definitely indicate worsening heart function. The heart and the kidneys are totally tied together, and they're oftentimes in conflict about what the optimal, say, fluid status needs to be or blood pressure needs to be. Those are things that we can talk about in the Q&A. We do echocardiography, which directly measures the pressure, not directly, indirectly measures the pressures in the heart as I showed you. And if we really need to know what exactly is going on, we do something called a right heart catheterization, where we put a catheter in the neck into the heart, which you don't feel, and that measures the pressures directly. And we do this very commonly in patients to help identify what their current situation is. What's their blood flow like? What's the blood pressure in the heart? Those are very important pieces of information. How do we treat heart failure? Well, here we're in kind of as we say, a data-free zone. Keep an eye on the time here. We use medications to reduce the fluid volume in the body, but we don't have any evidence that these things really work very well. And it's all based upon our collective experience as doctors. We use loop diuretics. This is a class of medications. You can see here, many of you are taking medications like this, furosemide or Lasix, bumetanide or Bumex, torsemide or Demodex. We use these relatively interchangeably, but they have different dosing and different indications, different appropriate uses. We also use a fair amount of mineralocorticoid antagonists, and these are these medications, spironolactone or eplerenone. These medications also help to augment the efficacy of these medications. The general idea is that if you reduce the amount of fluid in the body, the pressures in the heart are lower. If you reduce the amount of fluid in the body too much, you hurt the kidneys and you cause low blood pressure. So it's this careful balance. And in patients who are really, really sick and we can't get them compensated, we think about advanced cardiovascular therapies like mechanical circulatory support, pumps we put in the body to help circulate the blood in very certain people. And we also consider, in certain circumstances, heart transplantation. Again, I won't talk about that today, and I defer to my colleagues actually on the call who are more experienced than I am in these particular devices. Atrial fibrillation is treated with anticoagulation in almost all patients with ATTR amyloidosis because of a very high risk of stroke. And again, there is good data from this, but I'm not showing you those data. But the treatments basically involve either these direct acting oral antagonists called DOACs, new medications, or older medication like Coumadin or warfarin. And many of you are on these newer medications. I've listed the 3 most commonly used ones. These greatly reduce the risk of blood clotting, but they still, the counterbalance is they increase the risk of bleeding. And so you have to be careful about monitoring in certain medications like warfarin, and you don't put everybody on anticoagulation all the time. You pick the right people. And that has to generally, but I would say everybody with ATTR wild type amyloidosis or variant with atrial fibrillation will be put on these medications. We use medications to help regulate the heart rate. Oftentimes we use low dose of beta blocking medications like metoprolol. We don't use high doses of these medications because patients don't like, they don't feel well with really slow heart rates most of the time. And in some cases we put in pacemakers to help manage heart rate. And finally, for certain medication, for certain circumstances, we try to use medications to help regulate the rhythm of the heart, like amiodarone. Many of you are on that medication. Has a fair amount of toxicities, but with careful monitoring, the drug can be used quite frequently. And in fact, it's the most commonly used antiarrhythmic in cardiac amyloidosis. And under certain circumstances, can't speak, we might consider catheter ablation, like atrial fibrillation or atrial flutter ablations. What about low blood pressure? Sometimes if you over-diurese somebody, you can make them have low blood pressure. But in ATTR variant amyloidosis, particularly certain variants like T60A, PT80A, autonomic neuropathy is common. And in that case, the regulation of the blood pressure is abnormal. In these settings, we use drugs like midodrine or fludrocortisone or droxidopa to help push up blood pressure. And that's something that is can be very, very difficult to manage. But these medications are very, very helpful in maintaining people from having changes in position with blood pressure with position. They get up and they feel really, really dizzy. And we've seen patients with profound orthostatic hypotension that are really, really require these medications to make them not pass out when they get up. And finally, what do we do about implanted devices? There are certain circumstances when we want to put in pacemakers. Pacemakers are used to treat slow heart rates. They don't treat fast heart rates, but they keep the heart rate from becoming really slow. And the pacemaker is this kind of device. It's about the size of a silver dollar. It's placed in the left upper chest typically, and it has wires that go into the heart that regulate the heart rhythm. Sometimes we use different kinds of pacemakers, biventricular pacemakers, which we can talk about in the Q&A when we use those. But pacemakers are very, very helpful to keep the heart rate from going too slow. And as I said, in some cases in atrial fibrillation, they're very helpful in regulating the heart rate, which makes people feel better. And for fast heart rates, we use devices like defibrillators. Defibrillators are different than pacemakers. They have pacemaker function, but they shock the heart if it goes too fast. Under certain circumstances, we also use defibrillators or ICDs, implanted cardiodefibrillators, in patients with ATTR amyloidosis. So what can you do? This is my last slide as a patient. You can watch your sodium intake if you've got congestive heart failure. It's very hard to do so, but you got to start reading labels. You watch your fluid intake and don't drink too much, especially in the summertime. It can be hard to really maintain it when it's hot and you're maintaining and you're sweating. It can be really hard, but you have to kind of watch your weight, and that's so everybody should really have a scale and follow their weight carefully. And if their weight changes by more than a couple pounds, reach out to their doctor or their nurse practitioner. I'd urge people to get a home blood pressure monitor if they've got heart failure and certainly cardiac amyloidosis. If your blood pressure is too low or too high, then let your doctor know. And then follow for new symptoms, any changes of dizziness, palpitations, swelling, or shortness of breath. Even consider getting a monitor, a watch that monitors your heart rhythm to tell you if your heart rhythm changes, if it's too fast or too slow. That can also kind of help. I'm not advocating any particular heart rhythm, any monitoring device. So I think with that, I'll stop. I think I went maybe just like a couple minutes over, but thank you for your attention, and I'm looking forward to the questions in the Q&A.
Thank you. Thank you so much. Believe me, no one cares that you went over. They'd rather have the information from your mouth. I was going to say the horse's mouth, but that doesn't sound right. So
That's okay.
thank you so much. And we do have some questions that have been emailed in, but and we'll get to them soon. I hope you can hang around for a little bit.
I will.
Okay, great. And so now we're going to hear from people, our pharma, about clinical trials for cardiac amyloidosis. And first on the agenda is Alnylam. So do we have our gal from Alnylam here?
Yes, hello, how are you?
Hi, Gabriela. It's nice to see you. So I realize that you're not enrolling right now in your trials, but people are eager to hear about the trials, what information we have so far for cardiac. So and we'll put you on later on to discuss the hereditary neuropathy. So with cardiac right now, what trials do you have, even though you're not enrolling? Which ones do you have?
Yes, so thank you so much. So it's a pleasure for us to be here, and thanks for the opportunity to share what we have and in our amyloidosis clinical program. So we have, it's important for us to mention, I mean, the doctors already did, but in my remarks, I will be talking about trials in ATTR amyloidosis encompassing two disease types, which is ATTR amyloidosis, the hereditary type and the wild type. And I would also, just very quickly, I would like to mention that I will also be referring to two RNAi therapeutics. One is patisiran and the other one is vutrisiran. Both target the messenger RNA to suppress the production of the protein that is causing the disease, which is transthyretin. And many of you might know patisiran is an IV infusion given every 3 weeks, which has been approved for the treatment of polyneuropathy in patients with hereditary ATTR. And we have a new candidate that we're investigating that utilizes an enhanced delivery platform, making it more potent and more stable. So we need less dose, allowing this also for a sub-Q injection. And we're looking at it every 3 months. And I'll talk about later also.
Do you have slides so people can see the names of these drugs, and or can you at least give us the names? We can look them up ourselves if you didn't bring any slides.
Didn't bring. I'm happy to send you over something, Muriel.
Okay, so what drug are we talking about for cardiac TTR amyloidosis?
For cardiac, I'm going to be talking about two. About patisiran, which is the one we already have approved, and it's an IV infusion, and we have it approved for the polyneuropathy of patients with hereditary ATTR amyloidosis. But now we have trials on cardiac, and I will be talking about vutrisiran. So currently, we have two trials in cardiac amyloidosis. One is Apollo B. This is currently active, but just closed enrollment.
How many people do you have in that trial?
Yes, so this is a randomized phase 3 double-blind, placebo-controlled, evaluating the efficacy and safety of patisiran in patients with ATTR amyloidosis, wild type or hereditary with cardiomyopathy. Remember, we have it approved for the treatment of the polyneuropathy, but this trial is for the treatment. We're seeking the treatment of ATTR wild type and hereditary.
Right. How many people did you have in the trial for cardiac?
We enrolled 300 patients on this trial, and it's everything on track. And we should be able to have results like a year from now in mid-2022.
Now that's an infusion, right? Just
Yes,
that's
an infusion every 3 weeks.
every 3 weeks. Okay. And then what is the other trial?
The other trial is called Helios B. This is recruiting at this point. It's also a phase 3 randomized double-blind placebo-controlled trial where we are also evaluating the efficacy of, this is a new compound that we are looking at. We're looking at the efficacy and safety in patients with ATTR amyloidosis with cardiomyopathy wild type and the mutant type, the hereditary type.
Okay,
We
so
are
is that a
enrolling-
phase 1? Is that a phase 1 trial?
No, it's a phase 3 trial.
Phase 3?
It's phase 3 trial. We are expecting to enroll 600 patients. These trials are global, are multi-centered. We're enrolling patients from all around the world. We are trying to enroll 600 patients. And these patients, we should have results by 2024. And these patients also have to have confirmed cardiomyopathy, whether they have wild type or the mutant type.
Okay, let me break in here for a second. Okay, so but you're not enrolling in the United States, you're enrolling in other countries for this particular trial?
No, we are enrolling everywhere, globally,
Okay.
including the United States.
Okay, so it is open to enrollment right now?
Yes,
Okay.
right
so
now.
and that's with the vutrisiran. Okay, so
Yes.
that is a sub-Q injection. So it's sort of a sub-Q version of the patisiran, which is the infusion.
Correct. This is a sub-Q injection every 3 months.
Okay, every 3 months. And now we heard Dr. Berk tell us how happy he was with the results of patisiran, even though the trial was for neuropathy. He felt that it showed some favorable things with people with cardiomyopathy. Okay, so with vutrisiran and can people still, if they're on tafamidis or on, can they stay on tafamidis for this trial?
They can, but we don't have any data on any patients on combination with, vutrisiran or patisiran because, some patients are on patisiran for their polyneuropathy, but they also have cardiomyopathy. We don't have any data on combination therapy. That is up to the physician to, decide if they want to put them in both. There are patients that are in combination therapy, but we cannot advocate because we have no data.
Right, but with it being the standard of care right now, with Vyndaqel and Vyndamax, tafamidis being the standard of care for cardiomyopathy, you obviously cannot have a trial that with just a placebo and no drug when there is a standard of care. So if people, we want to let people know that if they are on Vyndamax or Vyndaqel, they can stay on that drug and still enroll in that trial. Do you have, when is that trial, do you have, where is that trial going to be in the Northeast? Is it going to be in the centers where we have doctors today?
Yes. It's in mainly the main academic centers in the Northeast. We are very ahead with the enrollment. And yes, Muriel, we do have some patients that, because like you said, the families is a standard of care. We have many patients that have entered the trial with the families at baseline. So they did have the families. So we should have some data in 2024 about these patients when they enrolled with the families at baseline and they were added on vutrisiran. The same for the Apollo B trial. We have some patients that they were on the families at baseline, and now they're going to be added patisiran IV infusion for the treatment of the cardiomyopathy. So at the end, we might have some data of what happened with those patients that were on both drugs.
Okay, what about people that have had liver transplants? Can they get, do they qualify for this trial?
Yes, we just had a study in patients with post-liver transplant, and we saw that, for patients to date, we saw that the reduction in TTR levels is safe for of patisiran in patients with hTTR, with polyneuropathy, with disease progression post-OLT, right? So these patients that have post-OLT and had disease progression, they had a good response to patisiran, and it has been consistent with what we saw in Apollo. So we think that patisiran had the potential to address this unmet need in this patient population. We just presented this results in amyloidosis in orthotopic liver transplant, the 12-month results. We presented it at PNS this past June. So yes, it looks also that this could help patients that have had a liver transplant.
Okay, great. Thank you. We'll move on. We'll see you again when we were discussing the hereditary
That is
TTR
good.
patients.
Thank you.
Okay, but we thank you so much, Gabriela. And now we'll move on to Eidos.
Hi, Muriel.
Hi there.
Hi, everybody. Can you hear me okay?
We can. Nice to see you,
Excellent.
Makenna.
Yeah, nice to see you too. So hi, everybody. My name is Makenna Paule, and I'm proud to represent Eidos Therapeutics. Muriel and Paula, thank you so much for inviting me to share an update with this group. So I don't have any slides to share, but I'd like to briefly talk about what we're up to at Eidos. Our team is studying acoramidis, which was formerly known as AG10 for both hereditary and wild type ATTR. So our first study, called ATTRibute-CM, is evaluating cardiomyopathy associated with wild type or hereditary ATTR. It's now fully enrolled, and our first results are expected to be read out early next year, so early 2022. We have another study that we're working on, which is evaluating acoramidis for polyneuropathy associated with hereditary ATTR. That study right now is not slated to have any sites in the US, but we expect that there will be sites in Canada, and we'll certainly keep you posted. So if there's any questions about what I've just shared or any questions about Eidos or acoramidis, I'm also happy to share a good email that would be helpful for folks to reach out to should they have any questions. Would it be okay to share that email in the chat, Muriel?
Why don't you, I tell you what, you send me the email privately, I'll have them send me questions. Send the questions to Muriel at amyloidosissupport.org, and I promise to forward them to Makenna, okay? How's that, Makenna? And let me just ask you a quickie question, okay? I'm guessing that you cannot be enrolling in the United States because there's a standard of care that would kind of squish up the trial if you have people on tafamidis and your drug, because they have a similar mechanism of action. Would that be the reason that is happening?
So what I can share is that this is our current plan. We're still early in the rollout. So like you said, there's approved products available in the US for patients with polyneuropathy symptoms. And as we continue to develop our plans, I can certainly share more info, but that's the plan for now.
Okay, great. And if anyone has any questions, just send an email to Muriel at amyloidosissupport.org. And if Makenna can't answer, that's just questions that she can't answer here on screen, but maybe there's some that you can answer later on for us, okay?
Thanks, Muriel.
We don't have very many questions coming in our Q&A. I think this is a very shy group. We're usually loaded, but thank you so much, Makenna. And now we will hear from Ionis. That's Gustavo, right?
Yeah, I'm here.
Gustavo, do you have slides for us today?
Yes, I will share just a few slides with you. Give me a minute here.
Sure thing.
I'm ready to go. Let me know if you can see my screen.
We can see your screen.
Perfect. Thank you, Muriel. Thanks for having me here. And it's always a pleasure to be here with you guys. So let me just give you a brief update on the trials. I have at least one good news for each one. So as you know, Ionis has the medication that was used to be called ION 682-884. This is the official name in the documents, but now we got our real, I would say, name as accepted in the United States as eplontersen. So now you're going to see us trying to make that name catch and keep repeating eplontersen instead of the usual numbers.
What is it called? Eplontersen?
Eplontersen.
Eplontersen. Okay, I wonder who came up with that one.
Yeah, we will keep repeating that and try to make a catchy one. But so far you can call it AON 682-884 or even Axia TTR LICA as it was known before. No problem at all for us, of course. So as you can see, we have two trials ongoing, the NeuroTransform and the CardioTransform, both phase 3 trials planning the potential registration of this molecule. My first news about the NeuroTransform trial is that this trial recently, I think maybe 15 days ago or 30 days ago, we are fully enrolled. There's a few patients still to be randomized, but the enrollment is complete. It was, if I'm not mistaken, 3 or 4 months before the plan. So it shows that it's going very well. And we're going to end up with more than 140 patients in this trial. You might have some interim analysis that you see there of week 35, all patients reaching week 35, probably by Q2 next year. It's something we're planning to imagine that we're going to be able to show, like Alnylam just did with Helios-A, great results. For the interim analysis, we have to have something like that by Q2 22. The other trial we are doing, as you know, is the CardioTransform trial. So the same idea of having a silencer working now on the phenotype of cardiomyopathy. This is a trial that we're very, proud of. It's the largest trial in amyloidosis so far, 750 patients to be enrolled. This is a trial that accepts tafamidis at any time. This, to my understanding, I might be wrong, but it's the only trial doing that. So we don't have any control over tafamidis. It's just you, the patient, and the physician who decides what you should take or not. If you need to take it, you can come to the trial receiving tafamidis at any time. You have to stop, restart, or if you don't have tafamidis, you start the trial and tafamidis became available for you, you are free to start at any time, 1 month, 6 months, 12 months. The trial does not have any control of that. It's you and your physician to decide. I can anticipate for you that in the United States, all our patients, maybe one in Chicago, but all the other patients are on tafamidis since baseline, and that's happening very frequently in Europe, South America, Australia, Israel as well. And I have the good news for this trial is the fact that recently, like maybe 10 days ago, FDA approved reduction of the safety monitoring from every week to every 4 weeks. Let me explain a little bit what is that. So this trial has a burden, let's be honest, which is to check monitoring your platelets and renal function every week during the trial, right? The patients are doing that very well. We are enrolling on that situation, but it's a burden. And we have been discussing with the FDA and using our data from the DSMB groups, showing all the safety data so far. And the FDA approved so far for the United States, of course, we moved the weekly monitoring, so weekly blood draws, to every 4 weeks, making much easier to conduct the trial and much easier to retain the patients on the trial. So this is a big victory. But for us, the most important thing is the label that comes with that, showing that a good analysis of the FDA and our DMC groups show that this drug is not causing adverse events in a meaningful way so far at this trial. And we are allowed, because of the safety profile, to reduce the frequency of monitoring. So this is a good news for us. This is what I have to say to you guys today, Muriel. I'm open to any questions, or if you want me to expand on anything.
Okay, so we have some questions here that we'll be saving for later, but one of the questions I wanted to ask you was, how does the drug, is this sort of a new improved Tegsedi? Is that what this drug is supposed to be?
Thanks for the question, Muriel. I did not present in the beginning. Imagine that we're a savvy audience here, and I don't want to waste much of your time, but it's a great question. Yes, eplontersen, or the Ionis 682-884, or maybe you heard before, Axia, TTR, LICA. It's you can say it's a follow-on compound of inotersen. So inotersen is the drug that Ionis and Axia have launched a year ago, maybe more than a year ago, with the polyneuropathy indication. It's a drug that works very well. There's some prizes for this, but it carries one burden, that is the weekly monitoring for safety parameters, which is important to be conducted, and has been, we could say, the issue for this drug. Good efficacy, but the safety, there's a question mark there. So this new drug, it's very similar to inotersen on its sequence of oligonucleotides. It's an antisense oligonucleotide compound, but it has similar to what the competition is doing on Alnylam as well, using other compounds to try to target the molecule much more specifically to the liver, so reducing a lot the dose that you need. So for example, inotersen is 300 milligrams every week, and this drug is 45 milligrams every 4 weeks, subcutaneously, painless, no adverse events there. So we are being able to reduce the dose in 27-fold to have similar or even better results in knockout the TTR protein. So yes, you can say this is an improved follow-on compound of inotersen.
Great, thank you. If we could have all of our presenters and all of our cardiologists on the screen and our pharma folks, we have some questions. So Bob, can you arrange that? Okay, great. We have a few questions. First of all, and this may have been said in the cardiac presentation. Okay, a question. Dick wants to know why the amyloid does not show up on an EKG. Dr. Ruberg.
Sure, I can answer that question. Why does amyloid not show up on an EKG? Because an EKG measures, it's a very good question. And so I think that what you can see with the EKG is indirect evidence of amyloid deposition, but the ECG itself, or EKG, that means the same thing. It's basically looking at the electrical impulses of the heart and the electrical conduction of the heart. And it doesn't tell you anything about the structure really directly of what's happening in the heart. So it's not the right type of test to look for amyloid deposition. You need to take a picture of the heart. And that's what the imaging testing like echocardiography or cardiac MRI that Dr. Sheikh mentioned, or nuclear imaging with scintigraphy. All of those actually are also looking at indirect measurements, actually, to be totally honest. But the ECG itself is just looking at the conduction. It's not sensitive or specific for amyloid.
Okay, thank you. Okay, here's a question for you, Dr. Berk. And usually we see this with hereditary TTR, this question, but this one is for wild type, which I've never seen before. What can be done to treat loss of libido associated with wild type TTR?
That's a tough one. I think the first recommendation I'd have is to have testosterone levels measured. In some patients, we find that they're quite low, and that supplementation can actually affect libido and overall well-being. Short of that, it's a little bit difficult. Wild type isn't advertised as having significant autonomic dysfunction, although there's probably an element of that we don't fully appreciate.
Okay, thank you. Okay, this is a question for Gustavo. If a person on inotersen for more than 3 years with normal and stable platelet counts needs to continue getting blood draws every 2 weeks, well, that's not really a question, it's more of a statement. Anyway, maybe you can get what they're trying to say, Gustavo. If a person on inotersen for more than 3 years with normal and stable platelet counts needs to continue getting blood draws every 2 weeks rather than every 4 weeks, what is it they're trying to say here?
Yeah, I think that this person is concerned with the commercial use of inotersen, which still requires every 2 weeks or every week, depending on the region you are, to confirm the safety parameters of platelets and renal function. We are having this change now in the trial, as I promoted here, but this is so far accepted to the new molecule, the LICA molecule, the plontersen, not inotersen yet, and it's still only for the study, right? So we still check every 4 weeks, and we're going to be, we have to be sure this is really working. So during a study, everything is still an attempt to find a conclusion. We still don't have the conclusion. We believe that inotersen might have some decrease in the frequency depending on the pharmacovigilance data and the discussion with the regulatory agencies. I don't have any news on that. So far, what we can say is that the new compound seems to be so far, what we can say, safe enough and not causing these problems, allowing us to reduce the frequency. There's nothing we can say the translation of these to the inotersen in the commercial setting so far.
Thank you. Dr. Sheikh, Fran wants to know, is genetic testing recommended for wild type patients? Is there a criteria followed?
Thank you for that question from the audience, and Muriel, thank you for asking. It is very important. So depending on how the diagnosis was made for ATTR wild type disease in this individual patient, we can miss the diagnosis of hereditary amyloidosis if we don't do a two-step approach. So I will assume for a second that a biopsy was performed, that biopsy of the affected organ was sent to a place like Mayo Clinic, where that tissue was analyzed through proteomic analysis, and it was determined that there was no evidence of an amino acid substitution. And so they said it was quote unquote normal TTR, and that hence it was called wild type disease. If you do not then chase that finding with genetic testing, data from Johns Hopkins led by Dan Judge when he was previously there, and Emily Brown show that 16% of the time you will actually miss a diagnosis of hereditary amyloidosis. The proteomic analysis is an amazing technology, very capable of finding the precursor protein at the amino acid level, but there can be times where it's missed. And so by doing TTR gene sequencing, you actually then will not miss that. We've had a few patients who were told they had wild type disease based on proteomic analysis, and we then did TTR gene sequencing and actually found hereditary disease. So, and certainly if you do a non-invasive test, meaning you don't have a plasma cell dyscrasia, you get a PYP scan, you are obligated to do the genetic testing because you will not know if you have wild type or hereditary disease. And there are implications in terms of treatment strategy, which Dr. Ruberg, Dr. Berk, obviously, and our industry partners have highlighted, and enrollment in clinical trials, and then not to mention all the first degree relatives who could theoretically be affected by making a diagnosis of hereditary amyloid.
Okay, thank you. Here's a question for the Transform trial. Okay, the TTR Transform trial. So that would be Gustavo, right? Is there a likelihood that at some point in the Transform clinical trial, if safety concerns allow, all participants will receive the drug as efficacy continues to be measured? In other words, is there a possibility that the trial can be unblinded and all get the drug?
Oh, this is a great question. It's very important for the patients. I'm a great advocate to have the participants receiving attention forever, right? They're volunteers to the science. They have to get back for that. So the trial is a placebo control, like most of the trials or all the trials nowadays. So during the treatment period, you will be or on placebo or on treatment. There's no way we can change that. At the end of the treatment period, this trial has an open label extension where all patients go for treatment, even if you were on placebo before, and you're gonna stay, and this is what we can commit so far, I hope to be even more, at least 3 years following these patients, regardless if you have this on the commercial available or not. Regarding stopping the trial earlier and move everybody to the open label extension and a treatment, this might happen in what we call an interim analysis. It's an attempt to give a look in the results before the end of the trial. Of course, this is done all well structured per the current regulations. And this might bring the results a little earlier than expected, but we cannot commit on that. But for sure, once the trial is finished and we are able to finish a little earlier on the right time, after that, everybody receives the drug for at least 3 years. That's the commitment.
Thank you. Okay, we have 2 COVID questions I'm going to ask the group, and then after that, we'll take our break because we're running behind. But anyone who's ever been to one of our webinars knows that we always run behind, don't we? Okay. This is my question is, have you heard of any ATTR people, and this would be for anyone, okay, who have either COVID-19 and or COVID breakthrough positive after fully vaccinated? I was wondering how they're doing. I've tested positive for COVID 6 months after being fully vaccinated with the Pfizer vaccine. I so far have very mild symptoms and was wondering what effect it has had on others. So any of our physicians have any experience with that?
I have, sorry for see people nodding and having some reaction. Amazingly, we have, to my knowledge, in our program, not yet identified a COVID-19 positive ATTR or AL patient. I think speaking to the fact that many patients have obviously chosen to be in isolation, at least during the peak pandemic. But based on what's available, I would imagine that the data that supports the outcome for patients who have been fully vaccinated in terms of mild symptoms as opposed to severe disease would apply for amyloid patients. I think the only group that there's data where it could be not as successful, or there may be more risk, are those people who are immunosuppressed. But again, without knowing the individual, the individual who asked the question, whether there's any evidence of immunosuppression, which is obviously not a treatment for amyloidosis, we hope that he or she recovers quickly. And I don't know of any reason to believe that there's higher risk because of it.
Any other comments on that?
Rick Ruberg actually headed up an effort to address COVID in TTR. Maybe you want to comment?
Sure. We definitely have seen cases in Boston of people who had ATTR amyloidosis prior to vaccination, but JB can append, but I haven't seen any of my patients who have been fully vaccinated test positive for COVID. I mean, I think part of it is that the likelihood of having symptomatic COVID is much, much lower is extremely low after vaccination. And so active surveillance does show that there's some people who do get asymptomatic and minimally symptomatic infections. But in the ATTR population, I have to say, none of the paper that JB is alluding to, which convened a lot of people around the world, this was earlier on the pandemic, before vaccinations. But I would say, in my experience, I haven't seen a lot of people who've gotten breakthrough infections. It's not impossible; it certainly happens. But I would expect that the course would be minimal, and there is this certainly theoretic, as Farooq mentioned, the theoretic consideration that patients could be immune compromised, and then have less effective and less robust vaccine responses.
The other aspect of the question, I think, that needs to be addressed is whether or not the disease directly affects a patient's immunity, and it should not. So we would anticipate that the response to vaccination should be complete, as it would be for someone without TTR disease.
Oh, that's good to hear.
I agree.
Okay, great. That's comfort. Okay, we've got lots more questions to answer, but we want to get through all the presentations before we get to them. And we do have a 10-minute break, which is very important to some of us. So we will take our break now and resume in 10 minutes. Thank you, everyone. I think we're back. Appreciate everyone staying on. We have more people now than we did earlier on. Okay, we're going to get to as many questions as we can as soon as we're done with our presentations here. And physicians, please don't worry if you go over time. We won't hit you with a hook if you're 1 minute over. That's not a problem. Okay, so now we're going to hear from Dr. Brannagan at Columbia University about ATTR with peripheral neuropathy or autonomic neuropathy. So are you ready, Dr. Brannagan?
Okay, so I think we're good. So thank you for inviting me. So I was going to be talking about peripheral neuropathy symptoms, diagnostic tests, and approved, or as I interpreted that, available treatments. And that's a lot to cover, like all of the other talks. So I'm just going to touch on a number of issues, and then there's time for questions. So there's estimated to be 20 million people in the United States with peripheral neuropathy, and there's many different causes of peripheral neuropathy, and hereditary TTR amyloidosis is one of the rarer causes of peripheral neuropathy. In a general sense, there's 3 types of nerve fibers, and the symptoms that occur depend on the type of fiber that's involved. So motor fibers, if they're affected, can cause weakness and atrophy or loss of muscle. That's my dog Luna, who hopefully will be quiet. But sensory fibers have both, if they're affected, have both negative and positive symptoms. So from loss of the function of sensory fibers, you get decreased sensation to either touch or pain or temperature or position sense, sometimes leading to balance problems. But there's also positive symptoms, which seems paradoxical, but if sensory nerve fibers are damaged, they sometimes become hyperexcitable, and then people get pain or burning or tingling or abnormal sensations. And then finally, there's autonomic fibers. These are the nerve fibers that are involved in controlling the internal organs. So one symptom could be orthostatic hypotension, where your blood pressure is not maintained when you're standing up. So you could feel faint or even pass out, or people sometimes get abnormal sweating or do not have appropriate sweating, or gastroparesis, sometimes night diarrhea, urinary retention, or impotence. So amyloid neuropathy is typically thought to be a length-dependent neuropathy, which is a common form of neuropathy where the longest nerves are affected first, and sometimes this is called a stocking glove distribution. So the symptoms often start in the toes, and if it progresses, it could progress up the leg, and then again, the long nerves in the hands can be affected, with typically the fingertips involved. So this can be for all of the symptoms. It can be for the loss of sensation. It can also be for the positive symptoms of novocaine or numbness-like feelings, as well as pain or discomfort. And also, if there is weakness, it tends to be at the longest nerves first. So often moving the toe muscles is the first sign, and then the ankle muscles if it progresses, and sometimes then the intrinsic hand muscles. So these are some of what I would consider the disabling symptoms of neuropathy. You can have weakness. You can have severe pain, though not all people with peripheral neuropathy even have pain. You can have impaired position sense, which affects balance and can lead to falls, and then autonomic dysfunction can also be disabling. So I just wanted to mention one issue. So we're going to talk primarily about polyneuropathy, which can be caused by hereditary TTR amyloidosis, but there are other neurological problems that can cause overlapping symptoms and can be confused, but they're not a polyneuropathy, and they're not what have been studied with the TTR stabilizers and the TTR silencers that we've talked about previously, and we'll talk about more this afternoon. So in addition to polyneuropathy, there is what is called a mononeuropathy, which just means a single nerve is affected, and carpal tunnel is the best known mononeuropathy, and is actually relatively common from amyloidosis, but it's not really from amyloid directly affecting the median nerve. It's from the connective tissue from amyloid deposits pressing on the nerve. And then radiculopathy or lumbar stenosis is also a symptom that can occur from amyloidosis. The symptoms are often different. Sometimes there's back pain or pain shooting down the leg. With lumbar stenosis, typically numbness or weakness is when people walk a certain distance. And usually if people get off of their feet, sit down or lie down, they're better, which is typically the opposite of what happens with peripheral neuropathy. Often patients with peripheral neuropathy, their worst pain or discomfort is when they're resting at the end of the day, trying to say go to sleep. So I'm just going to speak briefly about diagnostic tests that are used to either confirm peripheral neuropathy or look for other conditions. So EMG and nerve conductions, which is often just called an EMG for short, should be able to separate a polyneuropathy from a radiculopathy from a mononeuropathy, or if somebody has a polyneuropathy with a carpal tunnel or mononeuropathy on top of that, it should be able to demonstrate that. But EMG and nerve conduction study could be normal if only the small nerve fibers are affected. So the small sensory nerve fibers are the fibers that sense pain sensation or sense temperature, such as to warn you if you're about to get burnt on the stove. The EMG and nerve conduction do not measure those small sensory fibers. So if we suspect small fiber neuropathy, we often do punch skin biopsies. We take a 3 millimeter circular punch of skin, and the pathologist can actually count the nerve fibers to see if that's abnormal or not. Also, you could actually stain that tissue for with Congo red for amyloid. So sometimes it's used in that regard too. But in general, it doesn't provide an answer for the cause of a neuropathy. We do autonomic testing sometimes. It's autonomic testing primarily is focused on changes in the blood pressure and pulse as a reflection of autonomic dysfunction, often with a tilt table or manipulations with breathing. There's also autonomic testing looking at reactions to sweat that can be measured. And we can also do a nerve biopsy. I would say we almost never do a nerve biopsy to see if somebody has a peripheral neuropathy. We can usually tell that by the history or physical examination and confirm it with EMG or skin biopsy. But there are some disorders, and amyloid is one of those, that can sometimes be difficult to diagnose unless we look at the nerve. The more common reason that I have seen people with unexplained severe neuropathies that get a nerve biopsy, and that's the point that they're discovered to have amyloidosis, and then sometimes they get sent to us for treatment. So as far as treatments for peripheral neuropathy, generally there's no treatment available to directly regenerate nerves. For 20 or more years, there's been promising compounds, and there's new promising compounds in the laboratory that I think many of us are hopeful for. But at this moment, if somebody has a peripheral neuropathy, we have no treatment to regenerate the nerves. So I would say we have a two-pronged approach. One is we try to identify the cause of the neuropathy, and if we can treat the underlying cause, and in the situation of hereditary TTR amyloid, we now do have some treatments, then peripheral nerves on their own can regenerate if whatever is damaging them can be stopped or interrupted. And then simultaneously, we treat symptoms of neuropathy. So we have effective treatments for nerve pain. We have effective treatments for some of the autonomic symptoms, and physical therapy could be helpful for people with balance or strength problems. And I'm not going to talk more about the nerve pain treatments or the autonomic treatments because Dr. Karam is going to talk about that later. And then specifically for hereditary TTR amyloidosis, I'm going to speak about 4 treatments that have been studied for hereditary TTR amyloid polyneuropathy. One is tafamidis, which is not approved in the United States for peripheral neuropathy. As was said earlier, it was approved in the United States for hereditary TTR as well as wild type cardiomyopathy, but it is approved in Europe, and I'll show some data on its use in peripheral neuropathy. And diflunisal is also been studied and is available. I guess it's not really approved because it's a generic medication, but it's available for treatment for peripheral neuropathy. These are both drugs that stabilize TTR, and then there's 2 transthyretin silencers, inotersen and patisiran. So I think a variation of this slide was shown earlier. This shows just the general concept of the pathogenesis of the disease and where these medications can work. So people have a gene for a transthyretin mutation. The most common worldwide here is shown as the MET30 mutation, and then the gene translates to RNA, and the RNA translates to a protein, and RNA silencers can act at this point. And then the transthyretin circulates in the body as a tetramer, and it's been shown that the rate limiting step for amyloid deposition is the dissolution of this tetramer to monomers that then can misfold into amyloid, and the transthyretin stabilizers act at this location to try to stabilize the tetramer. And I think it's been discussed earlier, 95% of transthyretin is formed in the liver, though small amounts are produced in the eye and the brain as well. So this is from a study of tafamidis for peripheral neuropathy. The papers were in 2012. There was a double-blind placebo-controlled study of tafamidis versus placebo for 18 months. It was all in patients who had stage 1 FAP, so they could all walk unassisted, and they all had the MET30 mutation. And they looked at a scale called the Neuropathy Impairment Scale, which is basically just a measure of impairments on the neurological examination. So if you have weakness, that adds to the score. If you have loss of sensation, that adds to the score. If you have loss of reflexes, that adds to the score. And they use the neuropathy impairment score of the lower limbs. I'm going to talk quickly about 4 different studies, and all 4 studies used a variation of the neuropathy impairment score, even though all 4 scores are different. So this is the neuropathy impairment score of the lower limb. And it was what's called an intention to treat study. So that means that that's the favored way to do clinical trials, because if somebody drops out, maybe it's because the drug wasn't working or they have side effects. So you still want to include them in your analysis. But in this study, 20% of the people on the active drug, as well as 20% of the people on the placebo, dropped out of the study to get a liver transplant, which was is an effective treatment, was the primary treatment for this disease in 2012 and prior. So with an intention to treat analysis, even though you can see that the patients who were on tafamidis versus placebo did better, it was not statistically different. But when they looked at just the people who are actually on the drug, which was their preordained plan, there was a statistical improvement, and that was also seen on the quality of life scores. It was not statistically improved, even though the graph looks better, but it was statistically significant when you look at just the patients. So this data was looked at by regulatory authorities. The drug was actually approved in Europe and other countries in the world, but the Food and Drug Administration asked for a second study, and that actually was the cardiomyopathy study that was done later. Matt Moore is the first author of that study. And so that led to FDA approval for cardiomyopathy, but not neuropathy in the United States. But I show this just because I think it does show that there's some evidence that this can help with treatment for the peripheral neuropathy as well. And then this is another study that was an international study. It was led by Dr. Berk, who spoke earlier. So if you have questions about it, he could probably answer them. But it was a double-blind, placebo-controlled study. Diflunisal also is a TTR stabilizer. And they looked at outcomes out to 2 years, and they used what was called the neuropathy impairment score +7, which is the findings from the neurological examination, but also some nerve conduction measures. And there was a statistical difference at 1 and 2 years that you can see on this graph. And then also with secondary outcomes with quality of life, there was a benefit in some of the domains in quality of life, the physical domain and the mental domain. So this is another study that was done for inotersen, which is a antisense oligonucleotide. So it blocks the translation from RNA to the protein transthyretin. And this just shows data that when people got on placebo, their transthyretin levels continued to be at a normal level. And when they received the drug, the transthyretin level dropped down pretty quickly. The mean was 79%. There was an open label extension, which was talked about earlier with the questions for some of the other drugs that are currently in clinical trials. So at 66 weeks, patients who were on the placebo could cross over to the active drug, and the people who are already on the active drug could continue on. And you can see when patients went from placebo to the active drug, the TTR dropped significantly. So there's lots of data. I'm just going to show a little bit. So as we know, this is an aggressive disease. So the people who are on placebo, the neuropathy impairment score over about a year and a half progressed fairly rapidly. And the patients who are on the active drug improved substantially compared to the expected progression from the placebo. And then when patients entered the extension phase, or the open label extension, this dotted line is what would be predicted to be the ongoing progression. So the patients who switched from placebo to the active drug improved compared to what would be the expected progression, which is good. But what can also be seen is that the patients who are originally on the drug and treated earlier, a year and a half earlier, and then continued on the drug, the patients who had a year and a half delay in being treated did not catch up to the impairment or the loss of function after they were treated. So another way of looking at the data where the number, this is the neuropathy impairment score, that higher scores mean there's more loss of function. But in the original 66 weeks, 36% of patients actually not only stopped progressing, but improved. And this is actually data of the percentage of patients in the extension phase that had a less than 0 point change and improved. Okay. And this is the quality of life, neuropathy quality of life score that shows similar data. This is the placebo-controlled part, and then the open label extension where you can see the improvement compared to the expected progression. And in this study, in the original 66 weeks, 50% of patients not only stopped progressing, but improved on the quality of life score. And that this is data on the improvement with a less than 0 point change in the extension phase. So this is the final treatment that I'm going to talk about. So this is patisiran, which is also an RNA silencer, but it does this in a different way. It's a small interfering RNA, so it inotersen X in the nucleus, and patisiran primarily works in the cytoplasm of the cell by a natural occurring mechanism called small interfering RNA. So it blocks, again, the progression of the transthyretin. I could show a very similar slide showing the drop in transthyretin by approximately 80% when patisiran is given. But this is the outcome measure. So it's a different modification of the NIS +7. So a very similar but not identical score. And you can see the progression of the disease as was seen previously. This is a disease that progresses pretty rapidly. And then when patients got to patisiran, they definitely improved compared to the placebo. And actually, overall, they had a negative score, which means that there is actually improvement from baseline. And then that, with continued treatment, was maintained. When patients were switched to the open label extension, if you kind of extrapolate what you expect might be the continued progression, there is improvement. But I think, again, this is an argument for diagnosing this disease and treating this disease early. So if you wait a year and a half, patients can benefit from these treatments, but they don't catch up to where patients were if they were treated early. And this is, again, similar data with the same quality of life score, where you can see untreated, on placebo patients progressed, on patisiran they improved. And if you look at individual patients in the initial study, 51% of patients actually improved, and the totality of the group improved as well. So there's lots more that we could talk about all of those. This is just a summary. Tafamidis is an oral drug. It's FDA approved for hereditary TTR amyloidosis and wild type TTR amyloidosis and cardiomyopathy in the United States. It's approved in Europe for neuropathy. We've been talking about these as separate diseases, though I think probably most patients have a combination of some neuropathy and some cardiomyopathy, even though some mutations tend to cause more neuropathy and some mutations tend to cause more cardiomyopathy. And then diflunisal, or also called Dolabid, is a oral medication that's available. It's generic. It's been shown to show benefit in neuropathy. It's actually been shown, as was discussed earlier today, to prolong survival in ATTR cardiomyopathy. It is a non-steroidal anti-inflammatory medication, so there are some side effects that can occur: gastrointestinal symptoms, worsening heart failure, renal disease. So those are issues with this medicine. And inotersen is a subcutaneous treatment once a week. It's FDA approved for hereditary TTR amyloidosis in this country and other countries throughout the world. There are safety issues with this during the trial. There were 3 serious thrombocytopenic events. So it does require weekly, in the United States, it requires weekly platelet checks and biweekly kidney checks, because there were some patients who developed kidney disease. When this kind of regular monitoring occurs, usually you can see warnings of this, and there have not been as many problems with this as time has gone on. But it does require, it's administered in what's called a REMS program, so patients do get frequent blood monitoring. Usually when the drug is prescribed, somebody can come to the home and do this blood testing. And then patisiran was the final medication I discussed. It's a medication that's given intravenously every 3 weeks. It's FDA approved for neuropathy, and it's a pretty well-tolerated medicine. Some patients, I think it was about 20% in the clinical trials, had infusion reactions. So there are pre-medications that are given. A steroid called Decadron is typically given, as well as H1 and H2 blockers, and Tylenol or acetaminophen. So that's all I had. Thank you for listening.
Thank you so much. Now, I believe Gustavo said with the inotersen, they had changed the monitoring from 1 week to 4 weeks. Was that for this trial, or was that for another trial? I'm not really sure, but maybe Gustavo.
I'm pretty sure what he's referring to is looking at the new, the new compound. That's my understanding.
Okay, and thank you so much. We've got lots of questions, but we'll save them all to the end because we want to get all these presentations in. Thank you so much, Dr. Brannagan. I do want to say to our patients, okay, I realize, especially you newbies that are kind of just in it from the last year, a lot of this is overwhelming. You hear Ole and Apollo and Transform, and then you hear the name of the drug, patisiran, and then you hear it called Onpattro. And it is overwhelming, and we know that. So what we're going to do is we had a chart. We're going to update the chart so you can have more of a scorecard, okay, and it'll make it easier for you. And I realize more today than any other day that we really do need to update that chart and make it easier for everyone to understand all these drugs that are approved, that are in clinical trials, what their various names are, etc. So we will work on that, I promise you. So don't feel that you're alone being overwhelmed. I'm a little overwhelmed myself, so I totally get it. Okay, let's go next to symptom management from Dr. Karam at the University of Pennsylvania. Dr. Karam?
Okay, let me get closer to the camera here. Okay, these are, sorry about that. The objectives is to discuss the management of pain related to amyloid neuropathy and discuss the management of symptoms of dysautonomia. So let's start first with the pain and neuropathy. It really dramatically affects the quality of life. The neuropathy and the pain can affect sleep, mood, and other aspects of health. And the lack of sleep and the bad mood can also make the pain worse, and then they feed on each other. So really a bad vicious circle. What happens in people with neuropathy, there's damage to the nerves, which send a signal to the brain that there's something wrong, and the brain interprets it as pain, despite the fact that there's really nothing causing, let me rephrase this. Usually the nerve, they carry a sensation, right? So you can tell if something you're touching is hot or cold or normal temperature, if something you're touching is rough or soft, is if you step on something that is sharp, it sends a signal to your brain that, hey, pay attention, you're stepping on something sharp. When there's nerve damage, like in people with amyloid neuropathy, there's disruption of this message. The nerves become hypersensitive, they start firing on their own. Even if there's nothing sharp touching them, they do feel like something sharp is poking them, or electrical shocks. And unfortunately, that causes a lot of problems to our patients. There are many ways to kind of treat this pain. We can treat it at the level of the nerve ending, or at the level of the body of the nerve, or even more centrally in the brain. So there's no specific medication that we use for hATTR neuropathy. These are borrowed medications that have been studied more frequently in people with diabetic neuropathy and so forth. But we feel that probably they work on the neuropathic pain in the same fashion. They do work on the tingling, on the burning sensation, on the electric shocks, and the dull aching that people have, but they do not work on the numbness feeling, the dead asleep feeling, or the kind of pressure sensation that people have. Unfortunately, for these symptoms, we do not have any effective medication. The two main categories of drugs that we use are the anti-seizure drugs, which are the pregabalin and gabapentin and other ones, and the antidepressant, such as duloxetine, venlafaxine, nortriptyline, etc. There are also other options, such as topical treatment with the lidocaine or capsaicin, and opiates and derivatives such as tramadol and oxycodone. Unfortunately, all of these medications are going to cause side effects, and what we try to do is balance between the side effects of these drugs and the benefit to kind of improve the patient's quality of life as much as possible. With the tricyclics, which are, for example, nortriptyline, amitriptyline, and others, these cause sedation, so we typically prescribe them in the evening so people can benefit from the sedation and fall asleep easily, especially with the fact that the neuropathic pain and the burning sensation a lot of time get worse as people are relaxed and trying to go to sleep. It can also affect the thinking, makes you a little bit tired, confused. One common side effect, unfortunately, in these medications is constipation, and which is also something we see in people with amyloid. So we have to be careful about that. OH stands for orthostatic hypotension. The fact that some people feel lightheaded when they stand up can also be worsened by the antidepressant drugs, weight gain, and cardiac conduction block. The SNRI, such as duloxetine, which is the Cymbalta, and venlafaxine, which is the Effexor, these can cause nausea, loss of appetite, constipation, sedation, dry mouth, and anxiety. I typically try to prescribe them in the morning, opposite to the nortriptyline. Then the anti-seizure drug, such as gabapentin, neurontin, pregabalin, which is the Lyrica, These can also cause water retention, sedation, dizziness, weight gain, and blurred vision. And then finally, the opioids can cause constipation, nausea, vomiting, sedation, and as you all know, addiction. So some alternative treatment that are not very well studied, but we also recommend just because they have maybe less side effects than the other medication, massage, acupuncture. Some people benefit from putting their feet in cool water or warm water. I always tell people, be careful not to burn yourself because you don't feel the temperature very well. Some people crush a couple of aspirin tablets in the water and that may help. Some people like to put salt in the water and that may help. Alpha lipoic acid is a supplement that you can buy over the counter. And some people find benefit with that medication. Cannabis and exercise can also be helpful, but at the same time, if you're exercising on your feet, can make the neuropathy worse. So we usually try to recommend some stationary bike or aqua therapy. Now for the dysautonomia and the amyloid neuropathy, as you know, the nervous system and the nerve not only control your movement and your sensation, but they also unconsciously control your gut movements, your sweating and body temperature, your heart rate, your blood pressure, and also a lot of your sexual function. So the main 5 categories of dysautonomia are going to be the orthostatic hypotension, erectile dysfunction, heat intolerance and sweating issues, the GI problems, and the incontinence. The orthostatic hypotension, which is that sensation of lightheadedness when you stand up, when you move from a sitting to standing position, especially if you're after sleeping for a couple of hours and you try to stand up, you may feel lightheaded. If the symptoms are severe, people may lose consciousness and injure themselves, so it can be a very serious problem. And to combat that, we have to try to increase our blood volume, our hydration. So make sure that people are well hydrated. We recommend salt so they can retain the water, eat small meals so not a lot of the blood goes to the guts after eating, compression stockings, but these are not your typical compression stockings. These have to go really high up to the waist, and abdominal binder, because actually a lot of the blood is around the stomach area and not just in the feet and the legs. Another thing that we tell our patient is to elevate the head of the bed by about 30 degrees. That can also help with the orthostatic hypotension and with the unfortunate supine hypertension that comes as a result, meaning that when you're sitting or laying down, your blood pressure may be elevated because your body's trying to compensate, but then still when you stand up, there's no reflex that increases the blood pressure and the blood pressure drops. If all of these treatments fail, we recommend medications. The one that is most commonly used is midodrine. It works really well, very quickly. The problem with this medication, it can also raise the blood pressure too high. So we tell people not to take it if they're just sitting at home all day long, and not to take it before going to bed. So at least 3-4 hours or more prior to going to bed. Another medication is a droxidopa. And another one that we use commonly is the fludrocortisone. The problem with this one is will retain a lot of water. And you can probably realize by now that a lot of the medication that we may give to dysautonomia may actually make the heart failure or symptoms of heart failure even worse. So we have to really be careful with what we're doing. And being in the multidisciplinary clinic, I'm always talking with the cardiologist, asking them if it's okay to start this medication or not. One medication that is relatively benign, it's called pyridostigmine or mestinon. It's a medication that we use in other muscle disorders or called myasthenia gravis. But we also find that it's helpful for many of the symptoms of dysautonomia. It can help with the blood pressure a little bit. So if the blood pressure is very severely affected, you may have to do midodrine, but can also help with the gut movements if people have gastroparesis. So, and a lot of the time we try to give people medication that can work on more than one symptom. So, you know, hit more than symptoms with the same medication. With the GI issues, we try to educate people on using dietary measures, using fiber supplements, making sure they're hydrated. For the constipation, as I mentioned before, you may use pyridostigmine, Sennac-Colace, and Miralax, among other. For the diarrhea, you can use loperamide, Lomotil, or the tincture of opium. And sometimes, unfortunately, people have both constipation and diarrhea, and it becomes a fine line. A lot of people realize what works for them the best medication-wise. For the gastroparesis, which is that sensation when you eat, you feel full right away, you can use metoclopramide, which is Reglan, or pyridostigmine. Incontinence is another major issue. For urinary incontinence, we can recommend oxybutynin or tolterodine. In severe cases, then we have to rely on clean intermittent catheterization, unfortunately. And these medications can also make other symptoms, unfortunately, worse, like constipation and worsening of the cognitive function. Another very common problem in men with dysautonomia and with hATTR, and unfortunately, that's one of the probably first symptoms that appear in these patients, but a lot of time it's not discussed, but I think it should be because it's treatable. So erectile dysfunction, very common, but we have medication that can help with that. I try to use a short-acting drug because if people have side effects, and typically start with small dose to make sure their blood pressure doesn't drop or they have side effects from this drug. So that's it for today. I tried to stay within the 10-minute limit that Muriel gave me. Hopefully I was able to. Thank you.
Thank you very much, Dr. Karam. We really appreciate the presentation. There'll be lots of questions. I know we've got some neurologists on here. I know you have to leave soon, but we've got some other neurologists that can answer them. And then we also might be emailing you some questions, okay? So thank you again for joining us today. We really appreciate it. We appreciate all of our physicians giving us part of their day. Some of you, I realize, are working, you're on call. Some of you have a family obligation, yet you're all making time for us. I saw Dr. Maurer peek in before he had to go back to the coronary care unit. So, you know, we appreciate everyone's partaking in this. And now let's talk with Alnylam and Ionis about clinical trials for hereditary TTR. Alnylam, that would be you, Gabriela, right?
Yes, hello again. Hello. Yeah. So great. So thank you, everybody, because yes, thank you, Gustavo, for mentioning Hereditary. So now we're going to continue with our clinical update, but now for trials with patients with hATTR with polyneuropathy. We have one trial in particular. It's active, but it's not enrolling. We enrolled 164 patients already around the world, in the United States, around the world. This is Helios A, and it's a phase 3 randomized open label study. That is, we are evaluating the safety and efficacy of our new candidate, which is the sub-Q formulation every 3 months for the treatment of polyneuropathy. So remember, this is for the treatment of polyneuropathy, which is Helios A, and we also have Helios B with the same compound where we are looking at cardiomyopathy. So they are two different that we have there. So this study is 18-month duration, followed by, like they presented, Dr. Brannagan presented, sometimes these studies have an open label study. So this is a placebo-controlled patients we are looking at the drug plus some placebo data that we have from our Apollo trial. And after 18 months, all the patients that are on Helios A after 18 months, and we're starting that right now, they are going to be receiving all of them vutrisiran. So everybody will be on vutrisiran. So another important thing I think is that after 18 months, all the patients will receive vutrisiran, and half of the patients will receive the 25 milligrams every 3 months, and the other half of the patients will receive 50 milligrams every 6 months. So we might have some information also, some data on the 6 months. But for Helios A right now, the patients are receiving 25 milligrams every 3 months in a sub-Q injection. And we are trying to look at, the primary endpoint for this trial is, like Dr. Brannagan also explained, is the neurological impairment score for these patients. And we have 2 cuts of the data. So we analyze the data at month 9, and then we will analyze the data again at month 18. So we already have the results for month 9. And this was already presented at the American Academy of Neurology and some data at the PNS Congress also in June. And we're very excited to report, like, we have positive results from the 9th month efficacy assessment. So we saw that vutrisiran met the primary endpoint, which is the neurological impairment score, and all the secondary endpoints, which are, quality of life and gait speed in these patients. So we saw that the patients that were taking vutrisiran definitely had an improvement compared to those that were on the placebo arm from Apollo. And they also had an improvement in the impairment score and quality of life relative to their own baseline. So I think that's great, great news for the patients.
Gabriela, let me ask you.
Yes.
Now, have you presented any of this data to the FDA?
Yes. So because of this data, it was very positive, and the safety and the, very important that with the safety and the tolerability profile were very, very encouraging. And Alnylam submitted a new drug application that was approved very recently. So if everything goes well, and if the FDA decides to approve it, we might have the approval by April 2022.
Okay, so the FDA has accepted your application for vutrisiran to be approved for hereditary amyloidosis with polyneuropathy. So
Correct.
If this is approved by April 2022, which is when you expect it to be approved, then do you expect all the patients right now that are getting infusions with Onpattro to be transferred over to the sub-Q injection every 3 months of the vutrisiran?
That's a good question that we don't really know. I think it's going to depend on the patient, on the doctor, on the physician. They might want to do that because it's, the trials were similar. They were not the same, but, the patients are similar. So they might want to do that. We don't know at this point how many patients will want to transition from one to the other.
How many patients will want to transfer over from regular infusions that take several hours that they have to travel to the infusion center versus getting a shot once every 3 months, and you don't know if they're going to change over? Okay, well, we'll leave you at that. Thank you very much, and we will now go on to—
Thank you very much.
The next person. Thank you, and we'll go on to our Ionis person, Gustavo.
Hey, Muriel, thanks again. I think I anticipate a little bit what we are planning to say about the neuro trial. So I'm going to repeat here briefly. So the NeuroTransform is the trial that we are currently active and going with the eplontersen, which is the Ionis drug 682884, or also known as Axia TTR-like. I have to say that there's no secret here. We have a very, very similar trial in the design as the Helios A that Gabriela presented. We are, I would say, maybe 6 months to a year, 9 months behind the timelines of the Helios A. So currently, we have our patients all enrolled in this trial. So we are not enrolling anymore, and we're gonna finish with a little bit more number of patients that we are expecting. So this is good. So currently we are running this trial, and similar to the Helios A, we're gonna have an interim analysis around 9 months, 36 weeks in our trial. And we will have a review of those data and potentially, depending on the results, of course, submit to the FDA. We hope to have similar results as the great results showed by Helios A. I think this is great for patients having more than one drug go into the same direction and bringing more options, especially in a safety situation. Here, I think we are all in agreement that the treatment looks so far very effective. We are more concerned on the safety side. So far also looks okay. So I would think that I might have similar news, I hope, maybe in 9 months from now, Q2 next year, about the same level of analysis for the Neurotransform trial. Hope to bring good news for you guys.
Wonderful, thank you. You gave the drug so many names. I just call it Super Texetti. Okay, that's my name.
That works.
Okay, so less confusion that way. Okay, so now what we will do is we will move on to our special guest, Jeff Jahelski from Intellia, who's going to talk about CRISPR. I guess, if you don't live under a rock, you've been reading a little bit about it lately. So Jeff, take it away.
I'm trying to share my screen right now. Thank you to the amyloidosis support groups, the physicians that have come before me, both from the clinical sites, such as Columbia and UPenn, and certainly from the folks that I wouldn't be able to be here with, who haven't done everything to date at Ionis and Alnylam, and most importantly, the patients and the families who volunteer in the clinical trials. So thank you for giving me a few minutes here, and I wanted to set the table with something that you may have already heard earlier today, but I think it's just always important to repeat. So if I go page down, sorry. What I wanted to do is just kind of set the table again, and you may have heard this earlier today, so my apologies, but really pictured here in this cartoon is really, and if people can see my pointer, this is considered outside the cell, the liver cell. This is within the cytoplasm of the liver cell, and this is within the nucleus of the liver cell. And we've often heard the expression DNA gives rise to messenger RNA, which gives rise to protein. So if we start from within the nucleus and work our way out, this is really what we've been talking about with all of our presentations today. And if we look at how do some of our compounds work that we've been talking about or that are in clinical development, I hope that we can update that table, Muriel, with you so that we can provide the best information for patients and families as they're looking for potential treatment options. If we look at some of the things that we just talked about, if we look at tetramer stabilizers, they are working out here outside the liver cell. The protein has already been produced, be it in its natural tetramer form or in its monomer form, as mentioned earlier. And so our tetramer stabilizers that we've talked about, tafamidis, diflunisal, one in development, I think AG10 in development by Eidos, works out here by stabilizing that protein outside after it's been produced. We also just heard a great update from Gabriela and from Gustavo on different types of mechanisms being small interfering RNA or oligonucleotides. And they really are working at a level either within the nucleus or within the cytoplasm to disrupt the production of the protein. So stop the protein production leads to clinical benefit. And this is a term where we've also heard people use the term gene silencer. So if we look at those, and I'm not trying to take away from Gabriela or Gustavo, or maybe they could provide more information on that, but that is a nomenclature that we hear from those types of molecules, is they are silencing the production. When we look at what Intellia is trying to do with CRISPR-Cas9, we are delivering a CRISPR-Cas9 technology to the hepatocytes, so the liver cells. Then it gets within the cytoplasm, and then an aspect of the compound is delivered to the nucleus. where CRISPR-Cas9 and specifically Cas9 makes a very specific cut to remove that sequence of genome that has the mutation that leads to the misfolded production or the protein misfolding. So this is not something that has a replacement. We do not put a piece back into the genome. So that's a difference that you may hear from other technologies. There's wonderful things being developed right now for things like beta thalassemia, hemophilia, some of these other gene editing technologies where you are cutting and replacing. We do not replace with our compound at Intellia. We cut out the specific sequence within the genome that is the known mutation, and a natural occurring correction process called indel formation occurs. Our product is believed to be a potential single use for the rest of your life because you are going to be permanently editing the liver. As we mentioned earlier with some of our compounds, be it first generation small interfering RNAs, next generation small interfering RNAs, and similar with our oligonucleotides, there is a requirement for chronic dosing, be it weekly, every 3 weeks, monthly, we just heard every 3 months, but those still are requirements where you need to maintain compliance to that dosing schedule to keep the protein levels low to reap the benefit. What I'd like to do now is pause here and just switch to a different slide set of some information on that we've recently released on the first 6 patients that have gotten this first ever technology, and they are TTR polyneuropathy patients. So bear with me for a minute as I switch. Okay, so just to, again, these were slides that were presented by Julian Gilmore at the recent PNS Society meeting that our Alnylam colleagues also presented data on. I heard Gabriela mention a few weeks ago. But what I'm going to first show you is our animal work that sets the groundwork for why we were able to safely move into man. So NHP, to orient you to this slide, is non-human primate. And if we look at the horizontal axis, this is an axis going across time. And our vertical axis is our percent reduction of serum TTR protein in the non-human primate. And as you can see on this slide, we studied 3 active doses with a doubling from 1.5 to 3 to 6 milligrams per kilogram as a single dose. And then we also had a control arm in the top. So you can see our control arm, serum TTR for across the 3 animals. It is something that does fluctuate. And as you can see, as you go up in dose, after a single dose within 3 to 4 weeks, you had significant TTR reduction. This is, we are reducing the protein by the gene edit. Alnylam small interfering RNA reduces the protein. Antisense oligonucleotides reduce the protein production. So it's similar in that we're trying to do this. This is a single injection and it was effective for beyond a year. We are not continuing this study, but we will be doing this in other animal models for other disease states where we have longer term follow-up of this edit. I need to actually, sorry, this is not in slides. So let me move this over here. So the first human study that we did present preliminary data on is pictured here. It is found on clinicaltrial.gov. As you can imagine, with any gene therapy, we are taking a very cautious, conservative approach. We right now have 2 study centers open in the world that are screening and recruiting. We will have several more centers opening in the near future. But we purposely started with 2 so that we could, get this trial up and running while we move and open additional centers. It is a 2-part study with part 1 where we are looking at ascending doses. We just looked at ascending doses in the non-human primate. We are looking at ascending doses in people with polyneuropathy. And then once we confirm what we think is the optimal dose, we will expand into an additional set of patients with polyneuropathy. We are also planning cardiomyopathy work, as you've heard, from several of the other companies. We do need to look at both of those types of indications. We also all acknowledge that within the spectrum of each individual patient, they may have predominant polyneuropathy, predominant cardiomyopathy, or some combination of both. And that is an aspect that you have to partner with your physician on to say, what is the best treatment for me and where I stand on that spectrum. If we look at the first 6 people that we presented this data on, and this has also been published in the New England Journal of Medicine recently online, you can see that they are in their 50s. They are early on in their polyneuropathy disease state, having been diagnosed several years ago. And when you look at some of the grading scales that we use to assess their background, we see that they are early with scores of 1 in the New York Heart class for the cardiomyopathy involvement, and the PND score. Again, all subjects right now are scoring as 1. We do allow people in the study design to be further along in their disease, but this is where the first 6 people happen to land in. And as you can see, we have a variety of different genetic mutations, but this technology will work on all mutations. And as you can see, we heard about tetramer stabilizing therapy. We did have several people that were on diflunisal, and they did need to wash off of that to get onto our study. The first 6 patients, we use the term adverse events to look at what maybe people are more commonly familiar with the term side effect, that type of thing. And as we can see, we have relatively benign safety profile, and the study is continuing to enroll and screen, and we'll get to that in a moment. When we also look at the liver, because this is where all the action is happening, we just talked about, we do look at liver function testing, and we also look at coagulation because of the lipid nanoparticle that delivers just like similar to a lipid nanoparticle that we are familiar with Onpattro. And we see that we had no disturbance in the measures over time in the first 6 people. Here's the data on the TTR reduction. Compare it to the non-human primate. The first subjects received 0.1 milligram per kilogram, and as you can see, within 28 days, we will be presenting data later this year with longer-term follow-up. We did see a range from 47% reduction in serum TTR to greater than 55% reduction. When we tripled the dose in the next 3 volunteers, you can see that the TTR reduction, seems to have a quicker onset and more dramatic. And you do see there's one individual that reached 96% reduction of their serum TTR. We did hear that TTR is also produced in the CNS and in the eye, and our product does not cross that blood-brain barrier. So this is going to be reduction of circulating TTR strictly from the liver. So if we look at the means across those 2 groups, we see that in a dose, a proportional way, we do see as we triple the dose, we're able to go from 52% reduction average to 87%. We are continuing to dose. We've tripled our dose now, and patients are receiving 1 milligram per kilogram. We have commenced that dosing, and there are several subjects that have also screened or in the screening process and prepared to receive doses in the very near future. So in conclusion, it's the first demonstration of CRISPR-Cas9 in vivo in the world where there was not a need to insert, okay, and it's done systemically. This is a 2-hour infusion, similar to some of the other products where you do need to get a pre-medication regimen, but you'd receive this infusion over 2 hours and then no more infusions for the rest of your life. We look forward to sharing more data at the end of this year. This has been publicly stated by Intellia. So Muriel, it's not a plug to get back on the agenda, but I'm hoping that the timing just allows us to be always able to share with your organization and the patients that you support. Thank you for your time.
Oh, thank you so much. I think you can count on being on our agenda quite a bit in the future, Jeff. Thank you so much.
Thank you.
Let's have all of our panelists up there now, okay? So we've got lots of questions, and some of our panelists have sent me little private messages that they have some questions for you as well. So you'll be, everyone will, and that's what we like, nice free discussion right now. So okay, for our wild type people though, Jeff, let me ask a question. Okay, you're editing a gene that our hereditary TTR folks have that say your TTR is going to get all mucked up and go rogue. Okay, so for the wild type people that think, is there a future in this particular gene editing for me? Am I wrong in saying since their TTR is not going rogue because of a gene, this would not necessarily help them, or am I wrong? Tell me.
It's a fantastic question, because when we look at all of these graphs that we've shared today, we look at, and we call it serum TTR. That is both wild type and mutant TTR. It's total TTR being reported, and so we do reduce and stop the production of all TTR, being mutant or wild type, and so this will be efficacious in wild type as well. We anticipate it to be able. When I use the efficacious, let me correct my statement. We anticipate that it will have the same effect on reducing TTR. We have not the long-term follow-up data that our colleagues at Ionis or Alnylam have that relate TTR reduction to clinical benefit.
Okay, very good. And and the one other question that I have before I go to the other questions is, when do you think will this trial be brought to the United States, or will you expect this to be approved based on your data from the UK?
I wish we will need many more patients and long-term follow-up, as you see our colleagues are running hundreds of patients through trials. So we anticipate we will need similar type of development plans. This compound will be in study in the United States. I can't say yet when, but it will.
Okay, I think you have a few volunteers just based on some of the emails we've been getting. Thank you so much. Okay, for our neurologists, okay, we've got Dr. Keku, right? And we've got Dr. Brannagan on there, right? We've gotten some questions from our wild type and our V122I people saying that they also have neuropathy, but they're treated just as if they only have cardiomyopathy. I'm paraphrasing their verbiage here. So they want to know if they would be eligible for Onpattro or Tegsedi based on their neuropathy, even though they're treated more for cardiomyopathy. So Dr. Keku, will take you first.
Sure. I think, thanks for having me. I think a lot of this depends on what presentation occurs first. So as was discussed earlier, some mutations predominantly have cardiac manifestations, others have neurologic manifestations, whereas some can have both and present at the same time. So I think it largely depends on how the patients present, whether it's predominantly cardiac or neurologic. But yes, correct. If the patient does have neurologic involvement related to TTR amyloidosis hereditary, then they would be eligible for those two medications. But it kind of depends on how they may have presented.
Dr. Brannagan, what do you have to say about that? Thank you, Dr. Keku.
Sure.
Yeah, I would agree with Dr. Keku that I think if people have hereditary TTR amyloid and have neuropathy, even if the cardiomyopathy is predominant, I think it would often be appropriate to treat them with RNA silencing medication. With a wild type cardiomyopathy, they're not approved. Those drugs are not approved, and there's has been discussed. There's kind of rather minimal data about it for neuropathy. So I think many of us think that there might be some benefit for wild type neuropathy, even though just the whole concept of peripheral neuropathy within wild type ATTR is a little controversial. So definitely people with wild type TTR amyloidosis get neuropathy. We've published some work, arguing that it could be seen in maybe up to 30% of people, but then also patients have many other causes of neuropathy. So there really is not the data to support that at this time, and also not the regulatory approval for the two current RNA silencing medicines, but that may change over time.
One more question for you, as long as I've got you on the screen. Is it safe to take reclass for osteoporosis? I am on a trial Apollo B. I don't know what reclass is, but I'm sure you know.
Yeah, well, I don't know a lot about it. It's an osteoporosis medicine. I wouldn't think it would be a problem, but maybe somebody else in the group knows with more certainty. But I don't believe that's an issue. I think that would be not a problem with TTR amyloid.
Anyone else with an answer on reclass? No. Okay. Okay. Here's another one for neuropathy. I saw. Okay, it's about a product called capsaicin quitenza. Okay. I saw this product advertised today. It specifically talks about diabetic neuropathy. Mine is due to amyloidosis. And he would like to know if there's any benefit taking capsaicin. I hope I'm pronouncing it right. Do you know anything about that?
Maybe I'll let Dr. answer that, because I actually think you probably have more experience with that medicine than I do. But
as Dr. Brannagan said, if you have predominantly positive symptoms, so a lot of that pain, tingling, burning kind of sensation associated with your neuropathy, then capsaicin has been shown to have good effect for patients with those symptoms. However, if you have predominantly negative symptoms like a numbness, like a dead feeling, reduced sensation, then unfortunately it doesn't quite help. Capsaicin is essentially hot chili pepper paste. The higher doses and increased concentration tends to help a little bit better. There's been no specific studies looking at amyloid with this medication, but extrapolating from data with diabetes, diabetic neuropathy, HIV neuropathy, there's pretty good evidence for it.
Thank you. Dr. Lau, any more to add to that?
Sure. Yeah, I also use it kind of routinely for diabetic polyneuropathy. The thing I warn patients a little bit about is at the beginning of starting treatment, sometimes you actually feel a little bit worse than better, just because it's, as Dr. Kaku said, it's kind of a hot chili pepper as opposed to actually kind of irritate the nerves before it starts to feel better. So if you're planning to use it for amyloid, just kind of be aware of that as well. But it's a symptomatic treatment, so it's not supposed to change the course of disease. So that's why I think we're kind of comfortable with extrapolating the information from other types of neuropathic pain.
Okay, another question. Can anything be done for the bicep tendon tears associated with wild type TTR? Anyone have an answer on that one? Okay, Robert, we didn't get an answer for you, but we'll try and find one. Okay, here's another one for our panel. Can you explain what the pre-albumin test is and what it shows, both for patients who have hereditary TTR and those who are being monitored for it that have the gene mutation? Don't be shy.
So pre-albumin is basically the old name for transthyretin. So, you know, I showed and other people have showed today that when you treat, say, with the RNA silencing drugs, the transthyretin drops by 80% with the the early data from the CRISPR treatments. That also drops. The pre-albumin is just is the older name for transthyretin.
Okay. We use that measure as sort of with the TTR protein stabilizers to determine whether there's a biologic effect of the drug, the therapeutic. And the idea is that if you're better stabilizing the tetramer, that the TTR levels will rise because you're not losing TTR to the tissues as amyloid. But the direct evidence that the prealbumin level really determines or really reflects TTR stabilization is not completely established. So we would prefer to have a blood test that truly demonstrates whether the protein is misfolding in an unnatural fashion. We don't yet have that.
Okay. Are patients taking, I think we might have answered this, but let's ask it anyway, because maybe we didn't. Are patients taking tafamidis excluded from Helios B?
Well, no and yes. No, there was Alnylam set a limit to the number of people who would be on tafamidis at the start of the trial, and then would be randomized to whatever therapy they would get in the trial, and that would be 30% of the participants. They met that level. At this point, two things. One, Helios B is just about closed in enrollment. And two, you can only enter the trial at this point if you're not on tafamidis. There's still the possibility you could start tafamidis during your participation, but you can't be on tafamidis at enrollment.
Okay, thank you. And Gabriela, you're nodding on that.
Yes, thank you, Dr. Berk. That's exactly right. Thank you so much.
Okay, here's a question for Intelia. Okay, Jeff, how do you minimize off-target effects? CAS9 cutting only one strand, question mark? And how do you monitor for off-target effects?
So certainly off-target effects are something that we all want to make sure we have a thorough understanding on. And so really when you look at how you look at this both from an informatic, so you do a gene walk and you make sure that with the Cas9 sequence that you're going to use, that it is not something that can be technically, located in another part of the genome or in another part of the body. So you do a tremendous amount of bioinformatics is what it's called. And these are technical reports that do get reviewed by the regulators so that they too are understanding where we are going to be cutting and where we are saying we will not have any cuts beyond the hepatocyte. You do also, like all molecules, have to run an inordinate amount of animal work and long-term animal studies so that you are not only assessing your on-target effects, you are also assessing all other organs where potentially you will want to just determine we are not having any off-target effect. And that is a requirement, be it something like ours or any other molecules. You need to look at off-target effects of even small interfering RNA and oligonucleotides as well. So that it's really a combination of informatics and animal work.
Okay, thank you. Okay, Pat wants to know what's the current thinking, and this would be for all of our cardiologists, neurologists, Dr. Berk, and everyone. What's the current thinking about approaches for asymptomatic gene carriers? In other words, Dr. Berk, are you offering treatment if someone is not yet symptomatic, but they inherited the gene? Are you offering them maybe diflunisal since the cost would be lower, or something, or EGCG or doxycycline, or what's going on, Dr. Berk, at BU for asymptomatic carriers? And we'll go through everyone on this.
Yeah, so Pat touches on, as she usually does, on one of the next critical frontiers. So we're going from focus of neuropathy now to cardiomyopathy, and then having tackled that, the question is going to be in patients in whom we anticipate disease, is there a measure that we can use or a timeline that would prompt some initiation of therapy before there's end organ damage? So again, what's critical in solving this problem is having a blood-based assay that tells us when the protein is misfolding. And if we had that, we could be intelligent about this. In the absence of that, we can try to piece together in sort of in detective style what the timeline might be for people with that genotype in that family setting. and anticipating. But the problem is, from generation to generation, there may be earlier and earlier onset, some concept called anticipation. And the other confounder is that not everyone who inherits the mutation will actually express disease. So you could, theoretically, you could end up treating people in sort of an anticipatory fashion, but they may actually never express disease. So you're exposing them to a drug unnecessarily. All of that has to be solved. And what we do at BU is we carefully assess the patient, determine whether or not there's end organ signal of ongoing amyloid. We look at the prealbumin, trying to interpret the other influences that may modulate up and down that that protein level. And if we're convinced by timeline and by prealbumin falling levels that there may be some activity that we can't detect in major organ fashion, then we may initiate or encourage initiating a TTR protein stabilizer, not a gene silencer, but a protein stabilizer.
Thank you. Dr. Lee, we haven't heard from you yet, so let's get your 2 cents on that. What are you doing about asymptomatic people that inherited the gene? I can't hear you. Well, let's come back to you. I think you, Bob, maybe you can work with Dr. Lee and see why.
I can speak for Dr. Lee since we work together.
Oh, great.
So,
thank you.
Yes, absolutely. So I think, like Dr. Berk mentioned, we, as an asymptomatic carrier, they're not necessarily going to have a demonstration of the clinical disease. So we don't treat them preemptively. I think, if there was a blood test to show the misfolding and the level of TTR, they'd be able to check that, that would be nice. But for now, as in cardiology, what we do is we just check pro-BNPs, troponins, prealbumins, and kind of monitor those closely, as well as echo, and to see if there's any increase in thickness and left atrial enlargement, things like that, to see if there's any actual changes. But as for now, we don't treat asymptomatic carriers.
What if a patient says to you, hey, I watched my mother die of this, I watched my uncle and my aunt, I watched my big sister die of this, I want to be on something, I don't care if I'm symptomatic or not, put me on something. What do you do then?
I think that's a great question. I think, you say that I still would not necessarily put them on treatment, as, it can still be in a situation in that case where that person doesn't demonstrate the clinical disease. And so I think for somebody like that who may have a higher probability, I think we just monitor even closely. And I don't think starting somebody on like a diflunisal or something like that is unreasonable if there's any sort of hint that someone has a slightly increased BNP compared to prior, or troponin Ts, or thickness, etc.
Dr. Sheikh, what about you?
Thank you, Muriel. I love the answers. I will not be able to do better than the answers that have been put forth. I mean, particularly Dr. Berk's very thoughtful answer, and all of the panelists. We enter into a shared decision-making model. I wish that all of the treatments we're describing, I mean, obviously it goes without saying that if you're asymptomatic, you do not have a pathway towards a currently FDA-approved TTR stabilizing molecule, which is tafamidis. You won't be able to receive that. But diflunisal is obviously a drug that both Dr. Berk and other, through his clinical trial and his collaborators' clinical trial that's been published in JAMA, as well as the heart failure retrospective data that he highlighted earlier today, provides a nice signal. But the reality is we've all seen patients develop acute kidney injury, GI blood loss from these drugs. So they're not free rides. And so we enter into that discussion. Currently, we just surveil, watch them very closely, doing very similar things that Dr. Berk described in terms of looking at prealbumin or TTR levels, and then looking for evidence of end organ involvement. We are not currently offering treatment, though I have a feeling industry will eventually start beginning trials to help guide us. So I bet we will be enrolling patients at some point in the future.
Dr. Thomas, what about you? Are you more sympathetic to that patient that watched so many family members die and they're absolutely a nervous wreck, can't sleep at night worrying, and will only feel good if they're put on diflunisal? You're on mute. Dr. Thomas, you're on mute. All right, well, Dr. Berk, let's ask you. How sympathetic are you to that family member that's begging for treatment?
Tom, you want to take that?
Oh, so I mean, I wasn't sure if you were talking to me before, but I mean, I would agree with everything I've heard before. The one situation that I know there's been conversations with many of the companies that there are, plans to start thinking about this to study and in clinical trials. I think one situation that hasn't been discussed, and you might not call this a person asymptomatic, but it's the person with carpal tunnel syndrome that we know is from amyloid because it's been demonstrated pathologically. So as Dr. Sheikh said earlier, they would not be eligible for tafamidis or inotersen or patisiran because they don't have polyneuropathy and they don't have cardiomyopathy, but they do have amyloid. And I think that's a situation, that maybe that's where we need to do studies. But I think the first example I saw of that is a patient that Dr. Berk and Dr. Kaku have been following, and they actually initiated the person on diflunisal, and I've been seeing them. And I think that's a situation where I would, have a conversation about the risks and benefits, but it seems like that might be the time to potentially initiate a preventative treatment, and the pretty much the only option that we have at this moment is diflunisal.
Okay, so if we reword that question, then if someone has a carpal tunnel syndrome or had lumbar stenosis or something, bicep bunching or something, then would you consider putting them on diflunisal? And so Dr. Brannagan, sounds like you're okay with that, Dr. Berk, and Dr. Keku. So let's go back and ask. Well, let's go with Dr. Farooq. Are you there? Or I'm trying to get some doctors that haven't had a chance to participate yet. Dr. Lee, are you able to?
All right, let's see if you can hear this.
You're little. I can't hear you.
Sheesh, I don't know. I guess my computer is just not working.
We'll come back to you. Okay. Dr. Karam, oh, you're still with us. Great. What are your thoughts on getting someone on, let's say, diflunisal if they're, not really symptomatic, but have carpal tunnel?
Yeah, I don't think I have much to add to what everybody else said. To me, any evidence of amyloid deposition, so even if I do a fat aspirate and it shows amyloid, and if there's no symptoms, I don't like to wait until symptoms start. So I'm very aggressive with treating people, and I look very carefully for any evidence of amyloid deposition, whether it's in the eye, whether it's in the fat, or whether it's anywhere else, the heart or the nerve, or the autonomic system. So very important, because as Dr. Brannagan and Dr. Berk showed, the earlier you start treatment with this disease, the better the outcome. So I have people who are hesitant, family members especially, not the patient themselves, but family member who have, vitreous opacities or a little bit of carpal tunnel, a little bit of neuropathy, but they don't want to come to the doctor because they don't think there's anything to do. Well, I disagree. And we've all had examples where people don't have any shortness of breath or any heart symptoms, and you do a PYP or you do an MRI, and you find that there's amyloid already. So the thing is that with amyloidosis, it starts depositing, months to years, many years probably, before people start having symptoms. So they kind of accumulate until you reach a threshold, and you really want to try to be aggressive and try to stop it as early as possible. That's my personal opinion. Obviously, we don't really have a lot of studies to support that. There's some talks of maybe looking at serum neurofilament light chain to kind of try to detect if the neuropathy or the heart disease is starting earlier, looking at the TTR protein or pre-albumin and seeing if it's a risk of depositing or misfolding. So there's a lot of things. This is a moving target, but I totally agree. If somebody is just have the gene mutation, no symptoms at all, you look, you do the imaging, you do your nerve conduction study, your autonomic testing, you even do skin biopsy or fat aspirate, and everything's negative. In these patients, they should not be on treatment until we have any evidence otherwise.
It'll be interesting to see Dr. Wall's study. Dr. Wall is, doing the imaging study at the University of Tennessee. He couldn't be with us today, but he recently was taking on imaging patients that were not symptomatic, but had inherited the gene. It will be interesting to see where people light up on his image after being non-symptomatic. We'll have to find that out the next time we see him. Oh, Doctor, we have another one for you, Dr. Karam, as long as you're there. If sildenafil, yeah, thank you, is ineffective, what are the alternatives for ED associated with ATTR?
That question is for me.
Yeah.
Yeah. So so first of all, it's never black and white, right? You want to see, there are a lot of factors to look at. Are the people taking medication that are contributing or causing the erectile dysfunction? So a lot of the medication that we give for pain or for blood pressure, etc., they can cause by themselves erectile dysfunction. So that's something to look at. Second thing, looking at the dose. Are people on an appropriate dose of sildenafil, which is the Viagra? Do they need a higher dose? Third, is there also associated, I think Dr. Berk mentioned that, about hypogonadism. Is the testosterone level normal? So there are other things to look at the same time before saying the drug is not working. And then if that doesn't work, there are a lot of intervention that people can do. Unfortunately, we're going to have to discuss with urologists. I don't think I want to discuss this here, but urologists can have a lot of different options apart from just the Viagra. But I think very important to look at other reasons why the drug is not working. As I mentioned, medication that are causing problems, or low testosterone, or depression, or anything else like that.
Okay, great, thank you. All right, Dr. Thomas, we'll ask this one of you. How can one tell the difference between bloating, I guess they would mean like edema, and belly fat?
Usually with with bloating, you'll see the other signs of like systemic volume overload. They'll have like peripheral edema. They can also have elevated neck veins, and then you'll also see like what we call ascites. So there'll be like a fluid wave, or there'll be dullness in the flanks. Belly fat usually will not, if it's just belly fat alone, you won't have those symptoms. So those are some of the symptoms that you'll see there. Are you able to hear me there? Okay.
Yes.
Yeah, and so and then I think someone, you were asking me about diflunisal. I was having trouble with my audio. Again, like if it's not approved, I'm sympathetic certainly to the patients about that, but I usually will try to direct that sympathy more towards getting them enrolled in appropriate clinical trials, or at least talking about the limitations of those. Generally it's well tolerated though, except in patients who do have renal insufficiency, or if they're like at high risk for decompensated heart failure. That would also be another population I would avoid that medication with.
Thank you. Okay. Okay. Well, this would be for our Alnylam gal, Gabriela. Okay. What is the possibility of getting home infusions with all costs being covered by Medicare? And I know we've been trying to advocate with CMS on this. It seems that regular normal insurance that people have, does cover home infusions. Medicare Advantage covers home infusions.
All right.
Yet Medicare itself does not cover home infusions. So there's definitely an inequity here that's blatant, that it doesn't take a college degree to see this. So how is it hope that when your vutrisiran is approved, which is a sub-Q, that and everyone will transfer over, this will be a moot point? It won't be an issue at all because they won't need infusions? Or how are you, what are you doing about this?
So you were exactly correct. I mean, it's more likely to be approved when a patient has private insurance. Now, during COVID, we saw that some patients on Medicare were being covered, but I don't know when that's going to change. And you know that there's Alnylam Assist, and I don't work on Alnylam Assist, but I'll happy to share some names with you, Muriel, later on on an email for this person. They have this program, and I think when they work with the patients, they are able to find different, maybe to find different ways. I don't know how to do it, but I'm happy to send you, or Alnylam Assist is on there they also have the information on Alnylam Assist, and I think that would be the best way to go.
Thank you. Okay, next question. Will this be for our physicians? Anyone can answer. Should TTR levels be checked regularly when on silencers? Don't answer all at once.
Yes.
Okay, thank you. Okay, someone's offering us information on reclassed, that it's an IV biphosphonate used to treat Paget's disease, hypercalcemia, and osteoporosis. Okay, thank you. Should a POTS POTS, it's an acronym for something, you would know what it is. Should a POTS diagnosis be followed up with testing for amyloidosis where a grandparent had suspected disease? Anyone on POTS? Anyone on POT?
So the underlying etiology of postural orthostatic tachycardia syndrome is thought to be small fiber neuropathy. So if this patient truly does have POTS by a tilt table test, which is typically an increase in heart rate by about 30 from going from lying down to standing, then they should have an etiology to make sure, first a neurologic exam to see if they have neuropathy on exam. And if they do, then an EMG and potentially a skin biopsy to determine if they have reduced intraepidermal nerve fiber density, which would suggest small fiber neuropathy as the underlying etiology. You would also want to ask this person if they have other associated autonomic symptoms. Usually with small fiber and autonomic dysfunction, you would expect orthostatic hypotension, so a drop in blood pressure with standing, but POTS can certainly be a manifestation of that. And then once you determine there's small fiber, then you would do a small fiber workup, of which I would consider amyloid in the initial battery of tests to do when they first present. Sorry, that was kind of a convoluted answer.
No, it was great. It was an answer. We appreciate it. Thank you so much.
Can I comment? So I'm gonna a little bit disagree. I hate to disagree with Dr. Kaku.
Well, we love when this happens. It's fun.
Because I don't want to worry people. Okay, so people with POTS already have a lot of anxiety, and anxiety can cause POTS, and maybe about 20 to 30% of people with POTS have small fiber neuropathy, but the majority don't. So I would be careful. I wouldn't freak out to the person asking the question. I would talk with your doctor, especially if you're a young woman. I would not really be very, very concerned. But as Dr. Kaku, additional investigation are necessary. The other problem with POTS is the GI dysfunction is very common. So there's a lot of different dysautonomia, not necessarily related to amyloid. So I would approach this carefully and without, stressing a lot about it.
Okay, thank you. Okay, we're going to have one last question for everyone. Okay, and this is interesting. It's kind of a moral, ethical question here. Okay, I don't know if Gustavo, you and Gabriela can answer this, or maybe our neurologist or our cardiologist can answer this, but we'll throw it out to you. If you have a patient that's not improving on a clinical trial for either the Ionis drug or the Alnylam drug, and you have no way of knowing whether, if it's a blind trial, you don't know if they're on placebo or drug. How do you try and find out if they're on placebo so that you can either have them get off the trial and get on some real drug? Or what do you do in a case like that? Do you feel it's some sort of responsibility to cross the patient over to a real drug if you suspect, because everyone else is doing so great on the drug, that they might be on the placebo? So Dr. Keku, you're ready to answer this one?
Actually, I'm going to jump in because I don't think that's an appropriate question for pharma. They are sponsoring the trials, but the patient is under the care of the investigator. And every subject who participates in a clinical trial has the privilege of dropping out of the clinical trial at any time. There will be no unblinding when someone is not doing as well as they had hoped, because that's just part of the clinical trial. But again, they have the privilege, and they should lean on the investigator to try and get some perspective on how they should manage things. But there are some specified limitations to interventions that can occur while on clinical trial. But again, they have the privilege of just stepping out.
Great information. Thank you. I really, really appreciate all of you taking part in this. There are some questions that did not get answered, and what we will do is we will ask anyone listening, if you do not feel your question was answered, or you'd like another answer, or you'd like an answer from one of the specific physicians or panelists, please send an email to Muriel at amyloidosissupport.org, and we'll try and get that answer for you. Okay, we want to thank all of our panelists and presenters and our attendees. And Paula, I'm going to ask Paula to present a quickie on financial aid. I moved her to the last end because she told me there really wasn't much going on, but she does have information for you. So I do want Paula to speak on that. Paula, go for it.
Thank you, Muriel. I have already posted in the chat feature, and if you scroll back through there, folks, you'll be able to see the list of websites that you can go to. There's assistance websites from each pharmaceutical company that you can visit those, and they will help you if you're getting set up on your treatment. They'll help you see if there's any financial assistance available to you through their company or through their foundation arms that sometimes are able to provide free drug to participants that are on the drug. The foundations that are out there for assisting patients with financial assistance, right now they are out of funds. All of them I checked yesterday. There were no funds available, but several of them, the Penn Foundation, the Assistance Fund, which is TAF Cares, both of those have wait lists that you can sign up for. You have to sign up for them each year, and I suggest that you do that as quickly as possible, because if you wind up being put on the wait list, at least then you will find out when money does become available again. This is based on donations that they receive, so it can change at any time. It can disappear at any time. So you've got to be very quick about getting this. All of these funds start back up at the beginning of the year, but I would check with them probably starting in December. Start looking, because some of them may come on a little bit earlier. But there is some assistance out there. Don't give up. Excuse me. And just check with the pharmaceutical companies and continue to check with the foundations. If you sign up for the fund finder that Pan Foundation has, that will alert you when some of the funds open up. I did notice yesterday, though, that they are currently saying that HealthWell Foundation has available funds, but when I went to HealthWell's site, they did not have any funds available. So that has not been updated right now from the last time that there were funds available. So just, check at the beginning of the year. Unfortunately, those funds go quickly each year, and we have a lot of people that don't wind up getting any assistance, but just keep trying and checking with the websites to see if they have possibly opened up. And if you have any questions, you can email me at paula@amyloidosissupport.org, and I'll try to help you out.
Thank you so much, Paula, and thank you to all of our panelists and presenters and our attendees. We appreciate you all coming. Bob will make sure that today's recording appears on the YouTube channel and the ASG website as soon as he can. Give us a couple of weeks before you start to email. Also, it'll be up on One Amyloidosis Voice and on our, and we'll be letting our Facebook groups know about it. Until then, stay safe. Let us know how we can help. We'll be having, don't forget the survey when you leave. And I can't say enough about our great panelists. So thank you all so much, and we'll be seeing you again soon. Take care, everyone. Bye-bye.